Record on this computer. All right, so we are going to start talking today in TherEx about patient supervision, the role of the PTA, and kind of how we handle patients. We'll talk a little bit about settings as well, and also our clinical kind of partners that we go through dealing with, audiologists and stuff like that. So for each of these, I pulled a bunch of keywords out to see if there's anything that you're not understanding about these keywords. So let's take a quick look down through these keywords. Now, like the basic dimensional model, clinical decision making, don't worry about that. Are there any of the basic words you're looking here, like proactive, prompting, anything there that doesn't look familiar? Is there anything you haven't heard, at least words-wise? So Riley says no.
I think queuing.
Good. Queuing was one that I expected. Yep, good. We're going to actually talk about that, so that's good. That's one that if you didn't hear about it, we're going to hear about it today, right? Because I'm queuing you right now to see if you know any of these words. Warmth. So Raquel, warmth would be me telling you that I really appreciate you as a student, and I really like that you showed up on time today. Warmth is just showing compassion for your patient. Ooh, peripheralization, good. Peripheralization and centralization go the same way. Or not the same way, but they go hand in hand. We're going to talk about which one of those is good and which one of those is bad. Here's a hint, peripheralization is bad. Dominance, is that one? Oh yeah. Is that a joke? No, I'm just joking. Dominance is something that you might struggle with a little bit, Stephanie. I'm just saying I haven't worked with you enough yet, but dominance is owning the control of your patient, because some of your patients, whoo boy, they are going to try to control the therapy session. And so you have to have a little bit of a firm hand, a little bit of dominance and control over them. So Stephanie says it's a major issue. Well, we can work on that. Don't worry. So the good news is if there's someone here that you don't understand, we're going to go over them. And we're going to kind of work our way through them. So supervising the patient, right? There are always going to be challenges working with patients. It is pretty rare on a day where I'm like in an inpatient or an outpatient setting where I don't have a patient that sometimes makes me question my life decisions. No, it doesn't get that bad. But sometimes these patients just know how to get under your skin. And I think sometimes, especially when I'm down in Tucson, I think the director of rehab down there likes to schedule me with people that are opposite political views from me on purpose, just to see what happens. Doesn't really cause any problems, but it's just one of those that it's kind of unique, right? So supervision of patients during the intervention. Why do we need to? What's the major issue? Why do we need to supervise the patient during interventions? What's the major reason we need to supervise them?
For safety?
Yeah, safety. That's our major one. Prevent injury, right? Because they're already coming to us because they're probably hurt. And the last thing we need is to get them further hurt. And I know I probably mentioned this before, but what do you think is the number one reason PT clinics get sued?
False.
Nope, it's not false. You would think it would be.
Not being supervised?
What's that?
Like just leaving the patient.
Okay, that goes hand in hand with it pretty well.
Negligence?
Negligence is the key word, right? And we're going to talk about negligence versus malfeasance versus misfeasance a little bit as well. Not today, but in a future lesson. Major negligence is burns. That's the number one reason PT clinics get sued. I just had one of the PTs I know that's a hand therapist down in Tucson. Her tech put their patient on a hot pack, and it was a new tech, and the tech had been through the training program, which I'm not even going to get into that. Don't even get me started. And so the tech took the hot pack out of the hydrocollator and laid it directly on the woman's knuckles. No wrapping, not even the brown terry cloth thing that, yeah, right? Just straight, had the patient lay their hands on the table like that and laid the hot pack directly across their knuckles. And ended up with full thickness burns of her knuckles. That means the burn was all the way down to the subcutaneous tissue. And why do you think the patient didn't notice the burns? because the patient literally just sat there with the hot pack on her hands.
Desensitization?
Yeah, she had desensitization. She was a patient that had severe diabetes. So yeah, can we use hot packs with those patients? Sure, but we really got to pay attention to them, right? So it's terrible, right? And the tech's like, well, I didn't know. And that's kind of, I hate to say this, guys, but this is for those of you that are techs, when you guys become a PTA, I don't know is no longer an excuse, right? It's no longer, even if it's in a field, maybe you go into inpatients, your first day in inpatient, you don't get to say, I don't know anymore. If you're not sure, don't do it, right? Be safe. That was a really bad situation. Now, whatever reason the patient's not suing, I just got lucky with this patient, whatever, but just imagine that. Like, can you imagine what that PT feels like right now? Because, first of all, the PT had spoken with had 13 evals in an 8-hour day. 13 evals. Do you know how almost impossible that is in 8 hours? That's just insane. Right? So we got to supervise these patients. You guys are getting a license. That license says you will be taking care and protecting your patient. You also have to effective problem solving, right? Because sometimes things aren't going to work. How many of you guys are interested in getting, or at least working maybe in pediatrics? Any of you guys?
I am.
Yeah. So you'll find that problem solving is pretty much your entire life. Because you think you're going in with the best laid plans. We're going to do weed bowling today, and then we're going to do walking on the treadmill, and then we're going to do stairs. And you go in, and that kid is just a hot mess, and you don't get any of what you wanted done. And you've got to adapt and overcome that kid because that kid has his own agenda. And so you've got to problem solve and figure out, okay, so what can I do, right? When you're working with kids, a lot of time you've got to know all the recent cartoons and all of the songs. And if you're working with boys, watching wrestling, even if you despise wrestling, like I don't like wrestling, but when I'm working with kids, I tend to at least tune into wrestling. And like when I'm grading stuff, I'll have it on the background just so that I can know who is who in wrestling, so that when the kid's talking about coming at me and giving me the people's elbow, I know to dodge. And then making appropriate decisions. And when it comes to your boards, they're going to be asking a lot about making appropriate decisions. And when it comes to your boards, the number one thing that making an appropriate decision revolves around to is safety. If there's an answer that involves a gate belt, it's probably the right answer. If there's an answer that involves parallel bars for gate, it's probably the right answer because the boards are designed just on pure safety. So you need to have interpersonal communication skills, meaning between persons. You need to be able to speak to people. And I'm going to be 100% honest. If I can do this job, any of you can do this job. Because I am the most antisocial person there is. I really don't like people. Just don't. That's why I got into IT, is so that I didn't have to deal with people. But then I realized I kind of missed people a little bit and needed to get into a field that I felt like I was doing something. And so I got into PT. And I realized, well, people aren't all bad, but it's really difficult for me being a strong introvert to do this and not get frustrated. I have to talk to people that I normally don't want to talk to, right? Talking to some of the doctors really gets frustrating, but you have to learn how to get over that. You have to talk about different patient supervision methods because there's different. There's hands-on, there's hands-off. There's distant supervision, meaning giving your patient a chance to fail a little bit without being mother hen, right? We all know about those. Doctors can be mean. You're right. I'll say can. They're not all. I have some really good doctor friends, as frenzy as I get with anyone. But there are some that are mean. And, some are righteously, I hate to say it, but they're superiority complexes and that are righteous, right? If I see somebody that's a cardiothoracic surgeon that's successful, that's good. Like, for example, I'm gonna use a famous doctor for an example. Mehmet Oz. I dislike his stupid TV show. He a pusher of snake oils combined. But the dude is a brilliant cardiothoracic surgeon. Like, brilliant on levels we haven't seen in a long time. He's developed a lot of techniques that have improved cardiothoracic surgery. But Dr. Oz also pushes stuff like green tea for weight loss and stuff like that. So they can make bad decisions as well. Data collection. So when I first started the PTA, I used to carry a notebook around with me all the time, and I'd write everything I'm doing with every patient down, and that slowed me down. Because I would spend more time writing in my notebook than have to transcribe it to my notes. And you have to learn to be able to keep a little bit of that up in your head. You have to know what you did with room 212 when you're going to 213, because you may not get to document immediately. In the inpatient world, a lot of times you document at lunch and at the end of the day. So you have to remember everything you did up to lunch and then everything you did from lunch to dinner to get documentation done. So you got to be able to collect that data and keep it stored in your brain or somewhere close by. I know a lot of PTs that keep just a single note card in their pocket and they have their own little shorthand. So like 213 and there's just scribbles behind it, and their scribbles they understand what those scribbles are. Yeah, when I'm doing wound care, I can't remember everything I do in wound care. So I've actually got to record myself doing it because I'm recording sizes of the wounds, depths of wounds, and stuff like that. Problem solving, how do you fix things? And then responsive clinical decision making. You have to realize when stuff's working and not working. So what would be a sign that a treatment is not working for a patient? What would be a good sign that it's not working for a patient?
Like it's painful.
Yeah, okay. It's painful. It's more painful than they are existingly. Good. No progress. There's the big one, right? Anna says no progress, right? You've been doing this stretch for 3 weeks now, and their hamstrings aren't getting any longer. Ooh, okay, we got to change it up, because the more that you show no progress, patient continues to come back to the clinic. Yeah, right. That's a good one, Raquel. The more you show no progress, the less likely insurance is going to give you new visits, right? And then Raquel brought up a good point, is patients coming back to the clinic. We obviously want patients to come back because they're referral business, right? They keep coming back to us. That's a good thing. But we would rather them come back for new problems, right? If you have somebody that's coming to you and comes to you for 8 weeks for low back pain, and then 4 weeks later is back at you with low back pain, you might have to change the protocol because something you did didn't work, or they just didn't do their part. So why do we supervise? Well, we got to get relevant information and data. Yeah, I will. Yeah, that's a good point, Bianca. Some older people just come back to socialize too, right? And here's the deal is, and I'm torn on those patients, right? Because I think it's mentally and socially good for them to do that. But I also think it's not really, medical, we have this phrase, do no harm. And I don't see us doing a lot of harm when those patients keep coming back, even though we might, we're billing them obviously and stuff like that. If their insurance covers it, I can always find something to work on with an older patient, right? There's always something they need help with. And usually it's balance, right? The number one reason people over 65 see a doctor is dizziness. So, there's always something we can do, but they do have high deductibles, right? Yeah. That's the other thing, right? Yeah, they'll come to physical therapy in January for like 8 weeks in order to meet their deductible, because they know physical therapy is cheaper than going to, and they can break it up quicker than going to get some sort of x-ray or something. Establish enhanced rapport, trust, and confidence. So you guys will find as we go through this, I will say this phrase frequently. I get away with stuff that I probably shouldn't get away with. I'm going to be one of those open people. I will be one of those people, do as I say, don't do as I do. Because there are some times where I'm working with patients, I'm like, how did I get away with that? I'll joke with patients and I'm like, oh, that wasn't very good. Whoa, open mouth, insert foot. But I have a way to work with them that is very, very unique. And, every patient I've had both really likes me and really hates me. And I consider that a compliment. They really like me for the way I work with them, but they hate me because I push them. And my thought on pushing them is, the more I push them, the less they have to see me. Right? If I can push them and get them through therapy, great. You guys are going into the field as students. Out of all those, establishing rapport, trust, and confidence, what do you think the hardest thing for you guys to establish is with a patient?
Confident.
Yeah, trust is more. Confidence is confidence on your part. Yeah, establishing confidence on your part is probably the hard part. For them, it's trust. And Stephanie says rapport. So that may be that, Stephanie, that's possible, but I'd be willing to bet you're able to establish rapport a lot better than you think. Because the number one reason we establish rapport is just talking. You guys talk to me all the time, and I'm scary bear-looking person, right? But man, building trust, because you come in and you're like, you know, hi, my name is Riley. I'm a student physical therapist assistant from PIMA. And all the patient hears is what?
Student.
Student. Yeah, right. That's all they don't hear anything after that. And some of those patients are like, nope, I am taking a whole order of nope fries with a side of nope sauce and a nope burger. Get out of here. Right? But you got to convince them, look, I can take care of you, you know, and I may take care of you better than the PT did it because I've got some new stuff. Yeah, and you know, it's hard. I was, when I had my neck surgery, my posterior surgery, the doc had a student in that was helping doing my fusion. And I didn't know that. And I came out, and honestly, the student, when they closed my wound, did not close it very well. And I was really upset about that. But then I really had to think about it. And I thought about it, I'm like, you know, I didn't do the best on my first wound care either. This was the student's first time in surgery. He was nervous. And the doc brought him in because he figured I would be the least judgmental, right? If it came out and something, I guess if something screwed up, and he did kind of screw up the surgery, or not the surgery, but the closure. But yeah, so it's scary, right? You have to understand yourself and understand the patient's problem, because sometimes what the patient's problem is and what they think it to be are two different things. You know, for a patient, their problem may be they're thinking about balance, but in reality, their balance is stemming from dehydration. But all they're worried about is that balance. Why are you not getting my balance better? Well, you're not drinking water. Well, my balance isn't getting better. And you have to find a way to kind of bring those two things together for the patient. You assist in the management of the patient for all other clinicians, right? And provide therapeutic outlet for patient to voice his concerns. I would be willing to bet most of my time is spent listening to patients, even when I'm working with them, especially the older patients, because you may be the only person that's talked to them in 6 days, especially when you're in a nursing home, because nurses are in, out, and gone. You know, you come in, you're working with them, you're walking them down the hallways, and they're telling you about their second nephew's cousin's best friend's dog, and you're listening to them, and that makes them feel valued, right? All of you that have significant others, right? And just a question, do you know when your significant other is not listening to you? Can you tell? Yeah, right? Uh-huh. I got really good at that being married. Yeah. Oh, really? Right? Sitting here at the gaming controller. Oh. Yeah. Yeah, there we go, right? Sorry, what did you say? So when he talks about the girls at work, I tune out, right? So we all know that. We all know what that feels like to both do it and have it done to us. And you got to imagine these patients, they get it all day, right? So when you're sitting there and you're talking to them, you're like, hey, let's get up and go for a walk down the hallway. And they're like, yeah, man, my son today, he took money from me, and oh no, come on, talk to me about it while we walk. You've just got buy-in, and you just established that rapport there, Stephanie, with them without even doing much, because now they're going to talk to you about their problems, and they may tell you something that is what I call the breadcrumb to get them better. It is a good distraction for them, right? The other thing is, if they're talking, they're breathing, right? Because what do patients like to do when they're exercising? They hold their breath. They're doing pull outs, and they're holding their breath, and they're valsalving, right? Yeah, working in retail definitely gives you an up in that. I would give you that, Cindy. Anyone that's worked in retail has it. Or in my case, I worked in restaurant management, so I got all kinds of fun. I wouldn't call that retail. I'd call that hell. because managing like 3 restaurants, whew, oh boy. If you've never, I think sometimes I really joke about this. I think everyone should either work in retail or restaurants at some point in their life just to learn not to become a Karen. So what is our role as a PTA, right? Educate the patient about the disorder being treated. Now, does this, yeah, people tell you the biggest secrets and that, yeah, that'll be 4-7. My wife left me today. Do you have my Big Mac? Educating about the disorder. Now, what if you yourself aren't educated on their disorder? So how many of you guys know what Prader-Willi syndrome is? Does anyone in here know what Prader-Willi syndrome is? I'd be curious if anyone does. Okay, so you get a chart and your patient says on there, patient suffers from Prader-Willi syndrome. What do you do?
You Google it.
You look it up, 100%, right? Or, you know, if a nurse is by, I'm going to be 100% honest. My nurses are my best friends. And believe it or not, my CNAs are probably even my better friends. Because they do all the hard, that I give all up to the CNAs and the maintenance staff because they deal with stuff that is just insane. And I always try to help them because then in the end, they'll help me. I'm like, hey, Sue, I know I've heard of this before. What's Prader-Willi's? And Sue's like looking and she rolls her eyes again. Really, again, McKeever? It's when the patient has a chromosomal disorder that causes them to eat excessively and gain excessive amounts of weight. Right? So they literally have a disorder where they're gaining weight and it's nothing of their own free will. It is literally a chromosomal disorder. Right? But you look it up. Oh, okay. Right. So then you look, and the main thing I look up is what are my precautions? What do I got to watch out for? Right. I've got a patient that's got congestive heart failure with left-sided swelling. What do I have to watch out for? Right. Those are the things I'm looking at. But that doesn't mean you have to tell the patient every single detail about their disorder. It's okay to say, I don't know. Right. Even when you're out in the clinic and you're working with your CI, it's okay to say, I don't know. But it's also important to say, I don't know, but I will find out for you. I'll look it up. I'll get back to you on that. People respect you a lot more that way than just saying, ooh. Know the plan of care in and out. Know what your PT wants you to do and know the interventions. Encourage the patient to become active in their treatment. PT should also do this. I've worked with PTs that don't involve patients at all in their plan of care settings. And unfortunately, then the patient doesn't have buy-in. The more I can involve them in what I'm doing with them, the more they're going to do what I tell them to do. It's truth. Provide selected interventions, make observations and collect and record data, seek and accurately relay the information to the PT. Remember, we are the extenders of the PT. Support the PT, support their evaluation, and be the direct extension of the PT. What happens if you don't agree with the PT? Is that okay?
Yeah, but you should talk to the PT about it
There you go, right? And where should you talk to them?
in an office space that's like private.
Yeah, off the floor, right? I will openly admit I've had PTs that have disagreed with me openly on the floor. I have never openly called a PT out on the floor. They've done it to me, and I know that some people are just that way. You just accept that. But if it's something where I'm like, man, I don't think this is good. Hey, Pete, can I talk to you for a second over here? I got some questions about this. And ask them. Why are we doing, I'm not understanding what's the purpose of us doing ultrasound on this if it's not getting any better, right? And it may just be that he's like, oh, you know what? I didn't even really think about that. I just put it on there because I did my eval at 6 o'clock last night and wasn't really thinking when I did it. Do you think that happens? Yeah. Right. Imagine PT, like I said, my PT friend that I have earlier, 13 evals in a day. I hate to say you're going to mess up one of the documentations. It's just going to happen. Law of averages. So prompting is presenting a question where cueing is giving a direction. So I do a little bit of that, a little bit of both, don't I, when I'm teaching you guys? I prompt you guys, I ask some questions, and then I cue you guys. I lead you down the path, right? But just like the old adage says, you can lead a horse to water, but you can't get them drunk. I'm just joking. That's not what the old word adage says. It says you can't make them drink, right? You like that saying? Yeah. a horse would probably get more drunk than drinking. I'm just saying. So, as much as you want to lead them down this path, sometimes it doesn't work. For you guys, sometimes I'm going to lead you down the path and you're not going to listen to me. I have students that are out in the field right now that I get them prepped for the boards and they choose not to listen to me. Unfortunately, guess what normally happens to those students? I'm not saying I'm not good. I'm just saying if you don't listen, you typically fail the boards. So just listen a little bit at least. What do you think the difference between a verbal and a tactile cue is?
Tactile, like hands on?
Yes, tactile is touching, right? So you see me leaning over like I'm leaning here, right? If you'd come and go, come on, Mr. McKeever, you're tapping me, sit up, you'd be giving me a verbal and a tactile cue. You're telling me to sit up, but you're also tapping me on the shoulder, telling me to sit up. Stroke patients do really good with tactile cueing, where you're giving them some sensation to input in the proprioceptive system. Right now, you guys are, for those of you that are sitting down, your chair is giving you tactile cueing on your buttocks. This is telling you you're in the chair, right? My fan that is blowing air conditioning into my office is giving me tactile cueing because I can feel the air coming into my office. So let's talk about people on the rehabilitation team. Who do we have on our team that help us? The audiologist. Audiologists are going to deal with the ears, right? You'd be amazed at how many people have balance problems and it stems from their ears. Because if they've got balance problems, they probably got hearing problems too. And I always joke, what'd you say? Not just joking. Dietitian. Why do you think dietitians are important to us? I mean, the American diet is perfect, right? It's just great. Right? Nothing wrong with the American diet. Definitely helpful. Funny story about that. I do have a funny story. One of the first places I ever worked, like so when I did my first clinical affiliation, I'm going into the room and the hospital had these breakouts of the walls that came down with the patient's chart in. This was back when we had paper charts. I know, it's amazing. And I'm reading the patient's chart and I hear screaming and hollering coming from inside the room. And I'm going, somebody's having a bad day. And all of a sudden the door flies open, out comes two dietitians and a speech language pathologist. And as soon as they come out of the room, the next thing that comes out of the room is a potted plant at about 90 miles an hour. And it strikes the wall across from me. And I'm like, and they looked at me and they're like, good luck. So close the chart, go in. And I walk up and I kind of meekly walk in. I'm like, hey, Miss Sue, how are you doing today? And she's like, who are you? Oh, this is starting off well. Like, I'm from physical therapy. I'm Keith, I'm your student physical therapist assistant. I'm going to get you up today. Said, sounds like you had some problems with them. She goes, well, are you going to talk to me about my diet? No, not. I'm going to get you up and walking. They already talked to you about your diet because they're stupid. I'm 99 years old and they're here telling me that I can't eat a Big Mac because if I want to live longer, I got to stop eating Big Macs. I'm 99 years old. All my friends are dead. Know your crowd a little bit. I'm sorry, if you're 99 years old, eat your Big Mac. I'm just saying, like, my grandmother lived to 103. She worked at the soup kitchen and she drank like a fiend. And she swore to this day, the reason she lived there, she would say, the reason she lived so long is she smoked and drank. Right? Right, exactly. She's 99 years old. You know, she lived a good life. If she wants to have her quarter pounder with cheese or whatever she wants from McDonald's, I'm not, can we talk to her about a better diet? Sure, we can, but don't restrict her diet, telling her she's going to live longer. Good Lord. She saw 2 world wars. Like, I'm just saying, stop. So think about who you're treating, right? The OT and the CODA, right? They're going to be our hand-in-hand buddies. They're going to handle, so that begs the question, what's the difference between PT and OT? I'm sure some of you had that question. Did any of you ask that question when you were at the, like the pre-interviews and stuff like that with admissions or whatever?
Isn't it OT? Don't they deal with more of your ADLs?
Good. That's a good way of thinking. Yep, ADLs, right? Functional activities. CODIS, the C stands for certified. Like in Arizona, we're actually CPTAs. Almost every other state, we're LPTAs, licensed PTAs, but we just don't put the L there. I don't know why OTAs put the C there. It was just kind of a thing they do, so I don't question it, but a CODA is kind of what they're called. They're going to be licensed pretty soon too. Most of the states are doing away with certifications and going to licensing because licensing provides a higher level of responsibility with the patient, right? You're more required to pay attention to them. So good thing. It helps the ADLs. I like to think of it as PT really helps a patient get from point A to point B. And OT goes, I'm at point B, what now? How do I live my life? How do I get my drinks out of my cabinet? How do I do my dishes? Right? Because the big thing you'll hear a lot of times, and I hate this, is when, well, I mean, I wouldn't say that. I have a holistic approach too. So I wouldn't say it's purely holistic, Anthony, but I mean, I can understand part. They have a more psychological approach. I'll give you that. They get a lot more psych than we get as PTs and PTAs. You know, a lot of their basis of their treatments is based on the DSM, which is a psychological manual. They do help with fine motor skills. Good, right? But we can, doesn't mean we can't either. So the big thing I want to break you guys of is there's this big rumor that, well, PT does lower body and OT does upper body. No, not so much. Right? I just told you one of my friends is a certified hand therapist. Dr. Ovreskin spent tons of time doing hand therapy, right? Exactly, right? Thank you, Dr. A. They focus on doing stuff like just handling their ADLs and their IADLs, their instrumental days activities of daily living, right? The stuff that gets them to do their daily stuff. Our job is, man, can they get around and can they do the stuff? I'm proud of you, Dr. A. After helping Janelle get ready for her board, I'm done with that. I don't ever want to do hand therapy again or work on it again.
Oh my God, that's hilarious.
I'm okay. There's way too many police. Right? So there are partners. We co-treat a lot with OT because sometimes the patient's going to get tired and you need more than one hand. It's great when we have partners like that. The physician, right? And physician covers a very broad gamut, right? Because you could have an MD, you could have a DO, an orthopedic doc, right? And we have psychologists further down, so I'm not going to add those in as the physicians there, but you have a bunch of different things that follow under physician. Then you have the psychologist, PA, physician's assistant, and they're not true physicians, and I would quickly hasten you to not consider them full of physicians. It's just like nurse practitioners aren't full physicians. They have a lot more training, right? But a doc is still a doc. I'm just going to say that flat out. If you went to MD school, you deserve to be called a doctor. I'm just saying. They go through a lot of training that, it's way more than I could probably deal with, right? I always joke when we get ready for the boards is, you know what they call the person who graduates last in med school? They still call him doctor, right? So they work hard for their stuff. Psychologists, especially rehabilitation or rehabilitative psychologists, are specialized in working with the way somebody's mind works. And they can be really good for picking apart a patient's thought process, especially if you ever work in like the lockdown units or something like that. Rehabilitation counselor and the recreational counselors work hand in hand, right? Rehabilitation counselors help them get back to their kind of life they have. When I broke my neck, I had to see a rehabilitation counselor for workers' comp and vocational rehab. And, you know, their job was, what did you want to get back to, Mr. McKeever? Are you able to go back to being a PTA, or do we have to find some other kind of profession for you? What are your options? Right? Recreational counselors are usually in long-term facilities, and their job is to plan some of the fun. They plan the bingo. They plan the group outings to Albertsons, right? They have a hard job. I got to give them credit because they've got to keep some of those people happy that aren't very happy. RTs. I actually like my RTs because they take a lot of the gunk away from me that we used to have to deal with in PT. We don't deal as much with lung clearance. We still do. But man, they deal with what I call lung butter, Respiratory therapists can have the lung bladder. They also deal with putting intubation in and out, right? Dealing with the PEEP of the machines and stuff like that. SLPs, right? Speech language pathologists. Well, guess what one of their things is? Speech. But the one thing we forget about SLPs is they also deal with swallowing. So when a patient has dysphagia with a G, meaning they have problems swallowing, SLPs are great in helping them out and doing testing to see what's causing that lack of ability to swallow. Because if you can't swallow, what are you not getting in?
Food.
Food, yeah, right? And think of how sad life would be. Mr. McKeever would be very sad if I could not get my caffeine in my body. I'd have to start like mainlining it or something. Very sad, right? And you got to imagine, like, some of these patients go on diets that are liquid, where literally what they're doing is basically glucerna. Right? But that's what the speech language pathologist is there to help a little bit, is let's get you back to where you can have real food again. And then specialized, I put this at the bottom because I didn't have this before, but more and more and more, you're starting to see specialized PT, OT, and speech language pathologists, where you're specialized in geriatric care, or specialized in cardiac care, or specialized in hand therapy, specialized in recreational therapy, you know, dealing with patients getting back to their home, specialized in home health. And there is a market for that, right? I mean, it's a big market. If your problem is just your hand, seeing a general PT is great, and they have a general idea about the hand, but I'd rather see somebody that the only thing they deal with is the hand, right? When I was being seen for my neck, I was kind of disappointed that they didn't have any spine specialists at the clinic that I was being sent to for PT. They just had a general PT, and the general PT really didn't have a clue of what he was doing with spinal surgery, which kind of upset me. But there's all kinds of specialists out there. Vestibular specialists, people that deal with just balance and people puking. There's all kinds of specialties out there for you. And there are certifications you guys can go on afterwards, once you become a PTA, to become specialized in certain fields of PT. You can become specialized in pediatrics as a PTA. You can become specialized in geriatrics as a PTA. There's all kinds of silos that the APT has, which is what they call those, to become a little bit more specialized. So what makes a great team great? A goal, right? Think about this really quick. What has made, and I dislike the Patriots for football a lot, but what has made the New England Patriots such a dominant force for so long? Do your job. Yep, right? It's part of it, right? Their coach, their Bill Belichick. He keeps them on the goal. You got to give them that. I mean, if nothing else, right? Communicate open and freely. Being able to talk to or discussing your problems, right? Not holding those type of things in and letting them dwell and burn you up. Communicate honest and respectfully. Communicate professionally. I struggle a little bit here on this because my background is definitely not in professional communication, but you've got to be able to learn to do that. If I sat up here and talked to you like I talk when I'm normally out of teaching, I'd probably be fired in a minute because my language is colorful because of what I've grown up with, right? But I have to temper that when I'm here. It wouldn't be good to work with kids and talk that way. Communicate using professional language. Use medical term with professionals and lay terms with the patient, right? If you're talking to a patient about their labrum and their acromioclavicular joint and the subacromial bursa, and the patient's eyes just kind of glaze over, you've lost them, right? But when you document, you've got to say, well, the patient's pain was at the subacromial bursa, or it was at the superior lateral aspect of the shoulder. You got to be very specific and use med term. That's why you went through the course of Dr. Arreston. Use language appropriate to the patient's comprehension. Does anyone remember what I said the average educational level in Nevada is?
7th grade.
7th grade. 7th grade is our average education in the state. We are 46th, I think, in the country. So, I mean, the good news is we really only have one way to go up, right? But you got to remember that. Now, not everyone has a 7th grade education. You guys obviously have more than a 7th grade education, or you wouldn't be here. But some of your patients may have never graduated middle school. You got to think about that. And that doesn't mean they're stupid. I know some very, very undereducated, smart people. I know some people that are very undereducated, but they're really good at, the electrician work and plumbing work and stuff like that. Maybe school just wasn't for them. But that still doesn't mean their education level is equal to where you are, and you've got to kind of tone it down a little bit for them. Listening. I listen to you guys a lot. I don't know if you noticed that, but that's why I try to get you engaged a little bit, because if I don't get you engaged, I'm going to go nuts, first of all. You got to demonstrate some interest in the speaker. You got to get them kind of hooked, right? When you go to buy a car salesmen are really good at this. What do you like about this car? You ever hear that? What are you looking for in a car? What's your payment looking for? They're trying to get some interest drummed up in you. Once they get that interest, next thing you know, you're in the sales office buying a car and you came in just to look at floor mats or something. Provide opportunities for the patient to understand the concept of the problem or situation. Let them solve some problems. Don't be, right? For those of you that are parents, if you kind of are that helicopter parent that solves all the problems for your kids, are your kids going to learn?
No.
No, right? They've got to fall a few times, right? Now, I'm not saying let them fall down 5 stories, but they've got to, learn, we all learn that, right? We all tried to climb up on the couch when we were babies and fell on our bottoms and learned when we couldn't do stuff like that. Provide an opportunity to compare verbal and nonverbal communication. Verbal being spoken, nonverbal being not only just hands-on, but also the way you sit. What does this say?
Grouchy.
Grouchy. Okay, good. You right?
Closed off.
Closed off, right? Don't talk to me. Having a bad day, right? What if you're working with a patient, you walk into them, and you see them sitting like this for the first part of the session, and then by the time you start working, they're starting to move around with their hands and talk with their hands. Have you broken through?
Yeah.
Yeah. Right? I watch that, and I kind of miss that about not being in the classroom. I'll be 100% honest. I miss that a little bit. I have to keep your cams kind of off to the side so that you don't get recorded with me when I'm talking. And I don't get always look at all your cameras, so but I do keep an eye, and I sometimes keep an eye when I see John to make sure he's not falling asleep on me and stuff like that. Provide an opportunity to compare verbal and nonverbal communication. You just got to be able to do that. And patients may trust to be more comfortable with a good listener. Sometimes if you spend 3 minutes listening at the beginning of the session, they're more likely to do their whole session. Just wake after that. Good job. If they come in and they're like, you know what? Last night they didn't give me my pudding with my meal. And they're going, and you're like, oh, okay. Tell you what, I understand you. That I'd be mad if I didn't get my pudding too. How about we get through the therapy session, and I'll go out and talk to the nurse and see if I can get you a pudding, if it's okay with the nurse. You will? You get me a pudding? Well, if I can't get you a pudding, I'll try to get you a Jell-O. As long as it's not that green stuff. Now you've got buy-in because you just listen to them, right? And you guys know that. Those you have significant others. Sometimes you're coming home and you're just upset, and you don't really care that they're fully paying attention to you. You just want them there to listen to you kind of gripe and moan a little bit and get it out of your system, and then sit down and break out the Ben and Jerry's and the bottle of wine and get it over with. That's usually after your anatomy test, right? Isn't that the way it works? So be proactive in supervising. Don't be reactive. What does that mean? Be proactive, not reactive. What should you be doing?
Constantly watching them.
Yeah, constantly thinking ahead.
Yeah.
Right? Being the person that's like seeing the problem 5 feet in front of you. Because if you don't see that problem, I guarantee it's going to find you. Right? You're walking down the hallway, and you're walking down, and 10 feet up the way, you see a wet floor sign. Probably not a good idea to walk in that area. Right? So be proactive when supervising patients. Use probing questions. Right? Use open-ended questions to invite feelings, thoughts, concerns, and opinions. What's the difference between an open-ended and closed-ended question? I just asked you there. Was that an open-ended or closed-ended?
Open?
Open, yeah, right? Because I'm inviting you guys to speak. All right. If I say yes and no, right? That's closed-ended, right? If I say, are you in pain? That's a closed-ended question because there's pretty much only two answers. I mean, maybe somebody will answer maybe, but yes and no are pretty much your only two answers. But if I say, tell me about your pain, you know, show me where it's at. Let me know what it feels like. Those are open-ended questions. Those invite the patient to speak a little bit more. You know, when you're stretching them, how does this feel? Does this feel better than I did this? Right? What do you think about this exercise? It sucks. Well, okay. I really like this one. This is a lot of fun, right? I love it when my kid says that because then I'm chalking, I'm like putting a star beside that exercise because we might do that 5,000 times. Closed-ended are typically yes, no, or limit the feedback that you get from the patient, right? Where is your pain? Here. Oh, pretty much only get one answer. Or here. I love that. Where is your pain? Everywhere. Can you take that down to like a small area? Sure. My body. Thanks. When does your knee feel unstable? In the morning. When I go up and down stairs. Does your back hurt when you bend forward? Yeah. Okay. It's different than asking the patient, so tell me about a time that the back doesn't hurt versus the time that a back does hurt. Your back does hurt, right? It's open-ended then. It gives them a little bit of time to give you a little bit more. Dominance, exerting control or exercising control or influence. This is something I really don't have a problem with. We mentioned this earlier, but Stephanie said, you know, she's willing to admit she has a little bit of problem exerting dominance over people, and that's okay. Not everyone can be that forceful personality, but some of us are forces of nature. I'd be afraid of Riley if she was my SPTA. I'm just saying, no, just kidding. I'm joking, Riley. Leading, controlling, making things happen. That doesn't mean you are bossy, because there's a big difference between being dominant and controlling the therapy session versus being bossy, right? We all know that. We've all probably had leaders in our life that we followed and we're like, man, these people just know how to get us going. And then we have those people that are like, man, they couldn't lead their way out of a wet paper bag. They can't lead ants to a picnic is one of my favorite ones, right? Versus submission or passive. Sometimes though, you do have to take a little bit of a passive approach with patients. If you know they're hot and heavy and angry, sometimes it's a good idea to kind of back down and, okay, tell me about it. Let me know how it's going, right? Letting that kind of go for a little bit and then going, okay, let's get into therapy and asserting your dominance. Dominance is different than hostility. And as much as you guys will all, you know, like to disavow this, and almost all clinicians will disavow this, at some point in your career, when you're a clinician, you will encounter a patient that makes you hostile, that just rubs you the wrong way, and you close off to them, right? You have just insensitivity to their needs. Patients have that towards you a lot of times, right? But what about coworkers? Have any of you ever encountered a coworker that was like this? Lack of concern for the other's needs, just insensitive. Any of you ever have a coworker like that? And somebody's going to say all of them, right? Yeah, I can speak from example. I've had them, right? All of us have had them. Retail, exactly. Cindy's like, again, retail, everybody. It can make you question your career choice. You're exactly correct, right? But it can also make you a better person, can it? Because you're like, I don't want to be like, you know, whoever, insert their name. It's made me a better leader over the years because when I was going through IT, you'd be amazed at how many people in IT are openly hostile leaders. It's their way or the highway. That's just the way it is. And I've learned through the years, like, you know what, that doesn't, I love old phrases. You get more flies from honey, right, than you do with vinegar, meaning that if you're not as hostile, people tend to follow you. And then warmth, being caring, being responsive, being sensitive, right? I credit Dr. Ovreskin with this, hands down. She is very, very warm, responsive, and receptive to people, to the point that I've noticed how much she really cares for not only you guys, but everyone in general. She just has that very empathetic personality, right? That can also be really wearing on people. You know, if you're that person that you're constantly empathetic towards people and you're constantly open and trying to help people, it can wear you down, right? We've all had that friend. And I always say that friend that finds out you're caring and warm towards them and takes advantage of you, right? And everyone can think of somebody like that in their life. I'm pretty sure maybe a family member. For me, it's my entire family, and I'm going to see them next week. Yay. So think about this. Where do you fall on the spectrum, right? Does it change day to day, hour to hour, minute to minute, right? It's probably does sometimes, right? Especially when you're having just that bad day. And sometimes when you're just having that bad day, you need to go outside and scream or grab a pillow, get it out, get it off your system, right? For me, the other day I was having a really bad day. And so I went out and I ran way too far, and I came back home and I literally crashed for like in 2 hours, just passed out. But man, it got that hostility out of me. And you guys would never guess looking at me that I can become hostile. So how do we measure change? Well, in patients, we can measure it with strength, manual muscle testing, pain. The pains go from 0 to 10. What's the swelling look like? Is their coordination better? Those stretch reflexes you guys had with the DTRs. Range of motion. What do we call measuring range of motion again? What do we call that? What's that? The Greek word?
Goniometry.
What's that?
Goniometry.
Goniometry, right? Yeah. And I had a student once that when I asked that same question, the student said gonadometry. That's a totally different thing. So goniometry is the correct word, right? Measuring the hip, measuring the ankle. I didn't get a chuckle out of John for that one. I'm really sad. Hip, knee, ankle, elbow, all the joints we have goniometry on. That can give us a definite view if the patient's getting better, right? And ultimately, why do we need to know if the patient's getting better? Well, it's number one, good to know that what we're doing is working, but it's also because insurance requires patients to show improvement, right? It's gone are the days where we can just keep billing the patient forever. So here we go. I'm going to ask this before we get into this discussion. Can we modify the plan of care? I'm waiting for Dr. Reskin to jump in here. Can we modify the plan of care?
No?
No.
Okay. Do you hear that, Dr. Reskin? Are you happy? No, we cannot modify the plan of care. That plan of care is set by the PT. Can we provide the PT with some input into the plan of care if they ask us our opinion about something?
Yes.
Yeah, right? I've had PTs in the hospital where I've done vestibular and the PT hasn't done vestibular before. And the PT's like, hey, what do you think about, when we did that, the Dix-Hallpike test, which we'll talk about, what did you think? Right? PTs do value our clinical expertise, right? But we don't modify their plan of care. We can make adjustments in their treatment plan after consulting with the PT and receiving directions, right? Maybe the patient has progressed where TheraBand rows are no longer good enough, right? They're just at the point where TheraBand's not doing it. We need to move them to more of a Nautilus machine or get them on some free weights doing rows or something like that, right? Right, don't mix up plan of care and treatment plan, exactly, right? Now, some PTs I've worked with, I don't have to, they will trust my clinical expertise and say, if you think they're ready to go from TheraBand to the Nautilus machine, go for it, do it, I trust you. But then you're gonna have to know those PTs that if you make that small amount, even to the treatment plan, you have to cover it with them. I'm gonna change from red to blue TheraBand. They wanna know before you change that TheraBand, and that's okay. You gotta remember the PT is ultimately responsible for this patient, right? So they have a vested interest in keeping an eye on them. So don't worry, if you get a PT like that, that's okay. They're just overprotective of their patient. It's allowed. Yeah, it does. Yeah, so Dr. Reskin said the input the PT appreciates most to help them adjust plan of care is your goniometry, manual measurements, and other measurements. And just the stuff the patient may tell you that they never tell the PT, right? Because sometimes the patients will tell us stuff they won't tell Dr. Reskin or, Dr. O'Neill, especially if it's opposite genders, right? For a guy, it's really hard to talk about some things to, ladies. And for ladies, it's sometimes hard to talk to guys. I had a patient once way back in the day that was coming into our outpatient clinic for low back pain. And Kate was the PT and she saw him, did the eval. She evaled him on Wednesday. I saw him on Thursday. And we go into the treatment room because I had to do manual therapy on him. And he's like, hey, just curious, because I didn't want to say anything to her, but is it normal for me to have sexual dysfunction with low back pain? What else? Tell me what else. Well, I also have some numbness on the inside of my legs. Well, did you tell Kate about that? No. That's indicative of a very big medical emergency. But he was kind of embarrassed to talk to her about that because he was a big bad ENT and just didn't want to talk about it. But he was open to me about it. And because of that, we were able to call an ambulance, get him into surgery because he had actually a huge kink in his cauda equina. And they were able to fix it and catch it in time. So we do provide a lot of feedback that patients provide us subjectively. But he may not have said that to Kate ever. And we could have, there's some things that show that with cauda equina syndrome, which is what that's called, at about 36 hours, whatever happens is permanent. So thank God we caught it in time. But just because he spoke to me and didn't speak to her. And what I did was instantly, I'm like, tell you what, I'm going to put the hot pack on you. I want to go check on something with Kate really quick. I didn't just instantly run out and go 911 with my hair on fire. No, I went and I pulled Kate aside and talked to her about it. I said, hey, this is what I'm seeing with Billy Bob. And she's like, oh my God, it sounds like cauda equina syndrome. She came in and checked him again. And she's like, sure enough, cauda equina syndrome. We got to get you to the hospital. Right? PTAs provide direct information to the PT daily and keep the PT informed on the patient's concerning status, right? Just keeping them up to date. The number one way we do that is SOAP notes, right? Providing clear and concise SOAP notes because the PTs do look at our SOAP notes. In Nevada, they have to co-sign on our SOAP notes. So I know some PTs that literally just click cosign, 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 but I know a lot of them that read everything we put in there. And it helps them, right? Understand, though, that sometimes PTs are directed by the physician. Even though the PT may have a DPT, a doctorate in physical therapy, right? Or doctor of physical therapy degree. Sometimes physicians definitely, Dr. Reston says she reads everything. It's very helpful. Good. But we both can admit that there are some PTs that don't. And we just have to kind of be the best we can with communicate with those PTs too. But there are some doctors in town here, I tell you, I know from experience, the PT follows that doctor's protocol. That is it. There is no deviation. If you deviate from that doctor's protocol, the doctor will stop sending you patients. Dr. Johnson in town is one of those docs that has a very strict protocol on all of his post-surgicals. He's a really fantastic orthosurgeon, but he is just really particular about when you can do open kinetic chain, when you can do closed kinetic chain, when you can do weight bearing, when you can't do weight bearing. So sometimes the PTs aren't saying you can't do this because they don't want you to do it. They're saying it because they have a protocol to follow. Each PT has a different background, level, experience, and education. Just because a DPT is a new grad doesn't mean they are inexperienced and you know more than them. I struggle with that sometimes, being a PTA that's been in the field since, Fred Flintstone drove cars. I have to accept that sometimes those DPTs coming out of school know more than me. Most times. Variances will occur, right? It's not our job to change or modify the treatment plan or protocols without the supervising PT's direction and approval. What if the PT is not on site? What if you're an indirect supervision PTA and you think something needs modified in the plan of care? Or they met a goal? What should you do maybe? So indirect supervision means PT may be in another clinic and you're running another clinic. What could you do? Call them. Sure, right? Or a lot of the electronic health records nowadays, the EMR systems, they have an instant messenger system built into them. So most of us, when we're in the clinic nowadays, unfortunately have to have our computers with us wherever we go. And that message pops up and says, hey, John, Patient met goal 3, 4, and 5. We're going to need to set some new goals for them at some point. Would you want me to reschedule them with you next time? We are also going to be kind of responsible for making sure the patient sees the PT for re-eval. You got to think about it again. Like I said earlier, the PT I talked about, 13 evals in an 8-hour day. They don't always have the ability to keep track of when they need to do a re-eval with the patient, but we need to be responsible for that. We need to know when it's time to get a re-eval with the patient. How do we understand the philosophy of different PTs? Talk to them, right? Minimize confusion by communicating effectively and efficiently with supervising PTs. Speak to them. PT is ultimately responsible for the physical therapy interventions provided, right? So what happens if we disagree? Identify the elements of disagreement. Talk to them, right? Learn from the PT just like they're going to learn from you, right? And understand their rationale. There may be a very specific reason. I think of low back protocols as one of the big ones, right? The PT just has the patient doing extension activities, extension. They're doing everything going backwards. And you're like, well, why aren't we bending over and touching their toes? Well, they may be implementing a very specific protocol that requires extension activities, and they'll add flexion when they get to that point in the protocol. You know, it's not ours to say, well, I'm going to make them do flexion because I want to do flexion. No, there's a protocol. They're there for a reason, right? For those of you in the military, right? There were protocols in the military. You didn't just choose which protocols to pay attention to and which protocols to ignore. That wasn't the way it worked, right? Amanda, would you agree with that? You didn't just pick and choose what protocols you wanted to pay attention to.
Yeah, or else you would like get court-martialed.
Yeah, that's a good idea. That's the ultimate. Hopefully you just get yelled at, right? But yeah, there are protocols and they're there for a reason, right? There was a specific way you cleaned your rifle because if you didn't clean it that way, it could cause problems, right? My big thing that I always thought about was when you're aiming down the range, the end of the barrel is always pointed down the range. Why do you think the end of the barrel is always pointing down the range? So you don't accidentally shoot your buddy. Same idea here. There are protocols. There are reasons why they do things, but it doesn't hurt to ask them so that you can understand. The APTA is our guiding, that was good, our guiding body, right? They provide this physical therapist guide to practice that provides all kinds of protocols, standards terminology, delineates preferred practice patterns, promotes appropriate use of healthcare, increases efficiency, and reduces unwarranted variations in service. In that guide, this is the definition of a PTA, and I want this to sink into you guys. A technically educated individual who assists the physical therapist in the provision of selected physical therapist interventions. Physical therapist assistants under the direction and supervision of a physical therapist are the, and I want to underline this, are the only individuals who assist a physical therapist in the provision of selected interventions. Physical therapist assistant is a graduate of a PTA associate degree program accredited by CAPD. And CAPD is our Commission on Accreditation in Physical Therapy, right? So, reading that, what do you guys think about that definition? Is there anything that stands out to you in that definition? I already kind of showed you what stood out to me. We are the only individuals to assist the physical therapist. So what is that? What do you think that means? Where did THEX come from? Yeah, right? Brooke, by this definition, THEX can't do that, interventions. Where I come from in Pennsylvania, we had to struggle with this. Yeah, the PT needs us and we need the PT. It's a great observation, Truman, right? The PT can't do everything. Man, as much paperwork as a PT has to do nowadays. So where do THEX come from? What do you think? Why do you think THEX came out of the blue?
Well, I know that physical therapy is like being utilized more and more, so they probably needed the help.
Yeah, it's probably a lot. And at least in where I'm from way back when, and maybe Dr. Reskin can, if she has any comments on this, chime in as well. what I noticed is they started off as just being either back office staff, or they're the people that came around and brought the patient back to you and got you the towels and kind of cleaned up the clinic. And for whatever reason, PTA mills that need help, yeah, there's part of it, Bianca, right? And cost, John, right? But for whatever reason, their job kept expanding. And in Pennsylvania, this was about, so I left Pennsylvania in 2011. I want to say it was 2009. We had a huge Medicare audit. And Medicare came in and just fined so many clinics in Pennsylvania for overuse of techs. And almost overnight, techs vanished out of almost every clinic. They became people that got the hot packs, the cold packs for us, and the people that brought the patients back and then took the patients out, and that was about it. Because what the Medicare said was, hey, they can't touch patients. They're not skilled and trained to touch patients. That is the difference between you guys and a tech. You guys will be making clinical decisions on patients. Whereas a tech gets to say, well, I don't know. Oh, right? I burnt the patient. Well, you didn't tell me. Right? That's the difference between you guys. You guys are literally the extenders of the PT. So these are the 8 standards of the APTA for PTAs. I'm not going to make you guys read these. You guys went over these, hopefully in PTA 110 back with Dr. O'Neill. But, you know, the main thing here is, and I want to stress this is the core list of values: accountability, altruism, compassion and caring, excellence, integrity, professional duty, and social responsibility. Altruism is one of the big ones for me in there. That would clarify a lot for clinics. You're exactly right, Dr. Reskin, 100%, right? And in Pennsylvania, we changed the laws to read that a tech cannot, or we didn't call them techs, and we call them rehabilitation aides, and they could not provide any billable treatment. That pretty much eliminated everything. That solved all our problems. Anything that gets billed for, they can't do, right? Altruism. This is the one that confuses people. What does altruism mean? It's a big word. Well, not really that big, I guess. Do you think Dr. Vreskin and I have altruism for you guys?
Is it doing things for other people without expecting anything in return?
Oh, wow. Did you break open Webster's for that? That was great. That's exactly what it is. Helping people without expecting something in return. Now, that doesn't mean you work for free, right? I mean, sometimes you will. I've done charity work and stuff like that, but altruism just means that, you know, you're not expecting anything back from the patient. You're not expecting them to say thank you. They usually do. Sometimes they don't, right? But yeah, man, you don't get into this field because you don't want to help people, right? That compassion and caring goes in it. But here's my other thing: professional and social duty and responsibility. What that means to me is, and I'm hoping, and this is the main thing, that once you guys graduate, once you guys get licensed, once you guys are in the field, you need to give back to your field. How's the best way you can give back to your field?
Caring for your patients.
What's that?
Caring for your patients.
For patients, and then Bianca said it good. Becoming a CI. Yeah. Right? You guys aren't going to graduate without CIs. Your future generation of PTAs aren't going to graduate unless you guys become CIs. It is a fairly thankless job, being a CI. It's not like, you know, you get a bump in pay because you become a CI, you know, and a lot of times it means a little bit more work those times that you're taking a student, but it is really rewarding. And sometimes you get some of the best stories from that. I've got some great stories in wound care we'll talk about from when I was a CI, some gross ones and some funny ones, right? Because students do the darndest things. They just do. Right? But we have a duty to give back. And I think a lot of PTs forget about this. And I don't think it's always the PT's fault. And I'm sure Dr. Vreskin would attest to this. Sometimes it's the clinic. You know, the clinic just says we can't take students for whatever reason. And we've got some clinics where the CIs want to take students. They're open. They want students, but the clinic says, no, we're okay. We don't need that kind of trouble here. Right? But giving back to them, right? How do we measure this with students at CPI? And Dr. Reskin is going to go over this with you guys in depth right before the clinical affiliation. I think actually now I look at this criterion 9, I think that actually has been changed. I've got to change that on my lesson. So I got to go back and look at this to CPI actually now that I see that. But the CPI is going to be important. That's how they measure how you do, right? Where do you fall? Do we need a break? How are we feeling? Because I think I've got a handful of slides left. So do we need to take a break, get up and stretch a little bit? Where are we at? Yeah, we've got another 20 slides. Let's take a break, huh? What do you think? Sound like a plan? All right, so let me get back to where we are. That's where we were. So it is currently, I'm going to stop share real quick. So it is currently 2:15. Let's come back. Can we take a 10-minute? We'll take a longer one later. So let's come back at about 2:25. Is that fair? All right, take a 10-minute break, get up and stretch a little bit. And I'm going to start back here. And we're just going to kind of blow through the next section here. The next section is just a review of some body systems. It's not meant to teach you guys this stuff. Excuse me. All this stuff that's in here, you should have already learned. I'm hoping. There may be some stuff you're like, I don't understand exactly what that is. But most of what we cover here is just going to kind of be a review, right? Inflammation, we know it's a response to the body's injury or disruption of the normal process. It's what triggers our healing cascade or our healing effect. It's what allows us to get better. There's blood components, vascular, fluid, semi-fluid, and then neurological and cellular reactions. We can also end up in a state of chronic inflammation, right? And chronic inflammation with patients can be really difficult to treat, because this is just where they end up in this cycle of vicious inflammation that doesn't go away. I think of patients that have lupus or rheumatoid arthritis as one of these people that are stuck in this chronic inflammation cycle that their inflammation really truly never resolves. And I just, coming from having my wife who passed away, having to deal with this, I understand how hard it is to deal with chronic inflammation. Obviously, the common signs, heat, redness, swelling, pain are kind of the common ones that come with it. And patients don't always pay attention to these. The main goal of swelling is to prevent further injury to the area, and that's a normal thing. Acute inflammation lasts about a week, less than a week, 4 to 6 days, right? It's a result of trauma, where chronic inflammation can last 6 months or even longer. We know at body temperature, what's the normal secondary? Okay, good. Well, secondary is what? That's actually a really good question. So if I say the primary condition is the flu, you have a runny nose secondary to having the flu. Does that make sense, Brooke?
So it's the result of
another problem.
Okay.
Right? So let's say I have congestive heart failure. Because I have congestive heart failure, I may have peripheral edema. Congestive heart failure is my primary condition. Secondary is the edema. Does that make sense?
Yes.
Does anyone know what the other term for secondary is? That's actually a really good question. Thank you for asking that. There's another term for secondary you may see every now and then. It starts with an S as well. Is anyone starting to remember it yet? Hangman. What'd you say? Okay, maybe you didn't see it before. Sequelae, a sequelae condition. Guess what it means and pretty much means in Latin? Secondary. We just have to get fancy. You may see this in Medicare diagnoses, that a patient has chronic obstructive pulmonary disease, and secondary or sequelae to having that, they now have pulmonary fibrosis, meaning their lungs are turning to fibrous tissue. I don't know why Medicare likes using the term sequelae. I think secondary is just so much easier, but sequelae is synonymous. So sequelae, if you ever see that, it means secondary. and I'm going to use this in modern day here because how many of you heard from or saw this on Facebook at all or something like that? Well, the people didn't die of COVID. They died of pneumonia. So really, it wasn't a COVID death. Did anyone have a family member or see that on Facebook or Fox News or anywhere, something like that? There wasn't a lot of COVID deaths. People died of the cold. Well, no, the patients died of pneumonia, right? Heard familiar, right? They died of pneumonia because they had COVID. So pneumonia was the secondary condition. So a really good example of that is, does anyone know what this disease is? ALS.
Amyotrophic lateral sclerosis.
Very good. Look at that. You breaking out the big words. Amyotrophic lateral sclerosis, right? What's the other term for it? What's the more common, the colloquial term for it? Does anyone know?
Lou Gehrig's.
Lou Gehrig's, good, right? Good, because he was kind of one of the first people we kind of diagnosed this in, right? Or it became mainstream. And there's always something associated when you give it a name that sticks, right? Amyotrophic lateral sclerosis, overall, the body breaks down from the lateral into the core. So you basically retreat into your own body. You lose function of the periphery, and then you lose function of more of your arms, and then more of your arms, and more of your arms, and your legs, and your legs, and your legs, until you're locked into your core, until your core stops. Patients don't die of ALS. ALS is not a terminal disease. I mean, technically it's terminal, but they really don't die of ALS. They usually either die of pneumonia, or they die of something really sinister. What's that sinister condition there? A UTI.
Urinary tract infection.
Yeah, urinary tract infection, right? Think about that for a second. Somebody dies from a urinary tract infection. That's kind of scary, isn't it? You know, you can, for the most part, take care of yourself with cranberry juice if you got a UTI, for the most part, right? But man, when we're talking somebody with ALS that can't move, UTIs can be really, yeah, exactly, Stephanie. It can be really painful, right? Not only that, but patients with UTIs can develop psychosis. And so they may not even know they have a UTI, right? So ALS may be their primary condition, right? And the abbreviation for primary is 1 degree. But they die of a secondary condition or a sequelae condition. I know I went a little bit further in depth. Does that make sense, Brooke? Just want to make sure that I beat that like a dead horse.
Yes, thank you.
Awesome. That horse is dead. What is normal body temperature?
98.6.
Okay. What's the range? Does anyone know about the range in Fahrenheit? It's about 96 to 98.6, somewhere in that range, or to 99. We really don't consider a fever until they're above, I think, 99.3. That's why Celsius is so much better, because what's the normal temperature in Celsius? There's not a range. There's a number. 37. 37 degrees Celsius is your normal temperature in Celsius. And that just, for me, whatever reason, that just makes a ton more sense, because 37 degrees Celsius covers a little, because it's a base 10 unit. Aren't those people are always, well, I'm right there with you. I'm usually about 96.1. And don't forget, they're also scanning you with the little clicker, and that little clicker is off by about 2 degrees. Well, not off, but so you're probably somewhere around 96-ish, 97-ish. It's normal, right? So this is our normal body temperature. We know that, right? And you guys are going to have a comp on that with Dr. Sokel. Fever is a systemic response to infection. The terms for fever are A, having a fever, being febrile, that means having fever, or being pyrexic. What does pyrexic mean? If you break that down, it means being what? You heard the term, somebody said pyro. Yeah, having a fever, it just means being warm or having heat, right? So a 96.8 to 99.5 is what the book says. It's all kind of relative there, right? If you're over 100, you definitely have a fever. Other symptoms can go along with that: rash, sore throat, and runny nose, right? Know your own normal body temperature, because it can help you understand when you're sick. Signs and symptoms of having a fever, all these go along with it. All these kind of go along with having the flu and a cold as well, right? So all these are pretty common things we know. PTA's action for a fever: gather the relative data, related data. We take their temperature, right? What different ways can we take a patient's temperature? Well, we know the scanner. We do that at the school. What else can we take temperature?
Auxiliary.
Axillary, right? Stick a thermometer under their arm. Good.
Popliteal.
Popliteal, there is a temperature for popliteal, right? Orally, taking it in their mouth. Don't get confused, because a lot of students get confused with this. Hold on, let me find my little drawer. We have orally and we have orally. What's the difference there?
AU is to do with hearing.
Yes, AU is to deal with hearing. Good. So that's sticking that thermometer in their ear, right? Click. What's the most accurate method of measuring temperature? Rectally. Good. Yes. Rectally is the most accurate. Now, orally is probably the second most accurate. But rectally is by far, because that's actually measuring the temperature of the internal body cavity, and there's no, well, I mean, there may be some air there, but not as much air as, say, in the mouth. Because, you know, we always say we're all full of hot air, right? So how do we prevent infectious disease transmission? Wash your freaking hands. I'm just saying, right? I think this COVID, Dr. Vreska and I talked about this a few days ago. This COVID thing has shown us a couple of things. Guess what? Washing our hands and wearing masks. I haven't had the flu, or more importantly, every winter I get strep throat. I didn't get strep throat this year. I just am, because I got my tonsils and I always get strep throat. I was so happy not to get strep throat this year. Well, why? Because we washed our hands more and we protected each other, and social distancing. Exactly, right? I don't need to hug everybody. I promise. I'm not a big hugger. Right? But washing our hands, just doing something as simple as that. But it isn't sad that we actually had to tell people to wash their hands. I'm just saying. It's the most effective way, right? Hand sanitizer works along with that. I'm sure I've got a bottle floating around here somewhere. Yep, look, I've got a bottle somewhere nearby me at all times. It's good, but it's not a replacement for washing your hands. Saying that now, I want some on my hands. Treatment area should be properly cleaned and disinfected, right? If we're treating a patient, they may have to wash their hands. It's not bad. It's nothing wrong with asking a patient to wash their hands, right? Especially if you've seen them in there scratching their private areas and now you're going to work with them. This is why I'm going to preach to you guys. Do not shake a patient's hand. Think about this for a second. You walk into the patient's room in the hospital, you wash, you foam in, you wash your hands, and you go over to the patient and you're like, "Hi, Mr. So-and-so, my name is Bob, and I'm going to be your student physical therapist assistant," and you shake their hand. What have you just done to your hand?
Contaminated.
Contaminated it, right? Funny story I have about that. Remember I said students do the darndest things. I was telling this one student, don't shake hands, don't shake hands, don't shake hands. And he's like, "Yeah, but shaking hands makes me feel good." And I'm sitting out at the desk watching, and the patient's in there literally scratching themselves silly in areas that you don't want to touch their hands after scratching. And the student goes in, and I'm like, before I can even get up and say anything, is shaking hands with the patient. I'm like, oh my God, no, please go wash your hands again. Right? Because the patient was scratching his nether regions. Ew. Right? You never know what the patients are doing in there. Don't shake their hands. Just warning you. Fever and exercise. Some exercises stress the cardiopulmonary and immune system that result in further dehydration, right? Avoid these exercises during fever. Running may not always be the best when you have a fever, right? Especially long distance running. Fever and lymph nodes. If the lymph nodes are swollen or tender, it's a good sign that the patient's got a disease or an illness. Changes in skin color or pallor. Erythema, redness, is normal part of the inflammation process. It's also a normal part of exercise, right? You all do this when you get on the treadmill, chugging along, your face is nice and kind of normal colored, and then after a while it gets a little red because blood's really pumping. And then after a while your body adjusts to it and goes back to normal, right? Or we've all seen those guys overlifting. and they look like their blood vessels are ready to burst out of their forehead because they're not breathing, right? Erythema or redness is normal. What can other skin changes? Rash, right? I got bit by a spider and I've got a rash from that stupid spider bite. It annoys the crap out of me. Red streaks, redness with superficial tenderness, meaning you touch it and it hurts. Loss of skin color, it goes pale, right? So I'm going to give you a good guide to remember. This is something that has helped me through my clinical thing. Red, raise the head. Did anyone ever hear this one before? Red, raise the head. Pale, raise the tail. Did anyone ever hear that? If you've ever done CNA work or something like that, you've heard it. So what this means is if a patient is getting bright red, bring their head up. Because what does red indicate typically?
High blood pressure.
Yeah, blood flow, right? Excessive blood flow. When you've talked to pilots, one of the things, they're worried about blackout in the plane, but one of the things they're more worried about is red out, where all the blood flows to their head, because that can actually burst blood vessels in their eyes and they'll lose their sight, whereas blackout, they just pass out and hopefully come to eventually. So if they get red, sit them up. Right? And we're going to talk about a condition called autonomic dysreflexia eventually, that's important to sit them up. But if they're pale and they're going into shock, raise their legs. Why would you want to raise their legs?
To bring blood flow. Just like
Yeah, bring that blood back, because your legs are big blood dumps, right? They hold a lot of your blood. You lift them up a little bit, it brings more of it back to the heart, which means the heart can pump more of it back up to the head. Right? Those of you that have kids, right? What happens when the kid hangs upside down for a little while? What's their face look like? Beet red, right? And they just love, some of the kids love that, some of the kids don't. So if it's red, raise the head. If it's pale, raise the tail. If they're going into shock, lift their legs up. Bluing or cyanosis. What does that indicate?
no blood flow to a given.
Could be no blood flow, or more importantly, it means no what?
Oxygen.
Oxygen, right? And more importantly, even than that, it doesn't necessarily mean no oxygen. What it means is too much carbon dioxide. It means there's not a gas exchange happening, right? Sometimes you'll see that. Does anyone remember what the condition is when your fingers turn blue and cold? It's a contraindication to cold therapy.
Raynaud's phenomenon.
Raynaud's phenomenon, and then there's also Raynaud's disease, right? Good. That's a blood flow restriction problem out here in your fingertips and sometimes your toes and your hands, right? But what if my lips are turning blue? It means I'm not exchanging gases effectively. It means I've got carbon dioxide buildup happening, right? And this is something we don't think about a lot, or at least I didn't think about a lot before I went into physical therapy. Well, what happens if you have somebody that's not Caucasian? So you've got somebody of African-American descent, or, you know, even Native Hawaiian descent sometimes, with really dark skin, because it's really hard to see blue, right? It's not going to change as much. Where can you look for blue at?
The lips?
Yeah, under the lips particularly. So flip the lip out and the gum line behind the lips. Yeah, good job, guys. I'm impressed with that. Skin color may depend on natural skin or tones, right? Remember one thing though, and this is something that I have to stress because of the current climate that we're in right now. Doesn't matter what our skin color is, we all bleed red, right? We all have the same blood. Pale also looks a little grayish, right? Right? We all have the same blood. We all have the same stuff inside of us. We all have a heart. We all have a lungs, right? Skin color doesn't define us. Blood clots, man. So know the difference between a blood clot, a thrombosis or a thrombus, and an embolus. A thrombus is something that's stuck somewhere, right? Where's the common place that patients get blood clots at that get stuck?
Like calf region? Or
Calf region, good, right? What's that called?
DVT.
DVT, deep vein thrombosis, good. A thrombosis becomes an embolus when it breaks free and starts seeking out a new home. So let's say you have a DVT and you're exercising with them and that breaks free and starts going up the great saphenous vein, goes back to the heart, gets through the heart, gets sent out through the pulmonary artery to the lungs and gets out to one of those small blood vessels in the lungs and now blocks that. It becomes a thrombosis again, but it's called a pulmonary emboli. You're basically cutting off blood flow to the lungs. DVT is usually tightness or inflammation in the calf. It's caused by a blood clot in the legs, right? And it may travel to other places. DVT may not always go to the lungs. It may go to the brain, and they can have a stroke, right? So, you know, if patient's complaining about calf pain, you look at the calf and it's bright red and kind of shiny and it's hot. It's a good sign they might have a DVT. There's this test called Homan's sign. And if you've ever worked on a sideline of football field or something like that, because sometimes we're worried about when patients or football players get hit in the calves of them getting blood clots. Homan's signs where you take your fingers, first of all, you check for heat, right? You touch, you look, is it red? Are they complaining about pain in the calf? And then you take your thumbs and you press down between the heads of the gastroc. And if they're like, wow, it's a pretty good sign they have a blood clot, right? If you suspect a patient of a blood clot, should you keep doing therapy?
No.
No, right? That's part of your modalities, right? Patients that have blood clots, we don't want to get them up. So here's the question. What if you suspect the patient's got a blood clot and you're like, I don't want to do therapy because I'm not sure about it. You talk to the nurse and the nurse is like, yeah, they might have a blood clot. But what if they go and get a test and they didn't have a blood clot? Is that bad? That you didn't do therapy with them? No, right? It's worse if you did therapy and they had a blood clot and it broke free, right? So be aware of that.
Mr. McKeever,
Yes.
for the Homan's test,
Yes.
Is there like 2 ways to do that?
There's a couple different ways. Some of them are squeezing the heads of the gastroc. There's one where I saw that they push underneath the gastroc. I don't like that one. Because I think if I push underneath your gastroc, everyone's going to have pain. Just saying.
Okay, because I remember Dr. Sokel was saying something about like bringing the foot, just like raising the foot up or something.
Oh, yeah, you can do dorsiflexion. Yeah, it's part of it. You can do dorsiflexion with it. So he's basically, what are you doing at that point? You're stretching the calf out.
Uh-huh. Okay.
And honestly, if you push them into dorsiflexion and they're screaming in pain, you don't even have to touch the calf. You know they've probably got a blood clot.
And then what did you do again? What did you say that you do?
So the other part of the test is you take your hand, you kind of wrap it around the gastroc, you take your 2 thumbs, and you push between the heads of the gastrocs.
Oh, okay.
So you have to find the gastrocs, kind of feel up the gastrocs, find that little soft spot between them, and push.
Okay. Thank you.
That's the only time that you're allowed to, because Dr. Reskin will get after you if you're using pointy fingers. Right, Dr. A? Big hands to touch stuff, but at that point you kind of do have to push that way. What can cause a blood clot? Immobility, trauma, lifestyle. We know this. We've covered this already. The other term for blood clots is intermittent claudication. This is activity-related discomfort associated with peripheral artery disease. This is important to know because your boards love to ask questions about this. Did Dr. Sokel cover this a little bit in patho? You remember hearing about intermittent claudication? Maybe a little, even just a small bit? Petit peu? No? No takers? Okay. This is aching in the legs. Now, what if you have leg day? Your legs are going to ache. That's not intermittent claudication, right? This is usually with minimal activity, and it gets worse if you raise the legs. If both legs are sore and you raise their legs and it gets worse, that's intermittent claudication. There is a test for the treadmill that measures it, but it's not something we get really into. But this is a common condition of peripheral artery disease, especially later stage peripheral artery disease. So just know what that is, please. Peripheral artery disease just was kind of what it looks like. It leads to diabetes leads, so it can lead to non-healing wounds. Edema and swelling. Remember that true edema, when we're talking about pathological edema versus just edema from swelling are different. It's fluid between the interstitial spaces or between tissues. We use tape measure to measure it. There are terms, brawny, pitting, dependent edema. We'll go over those later when we get into wound care. Don't worry so much about it. The main way we test it is either circumferential, measuring around it, or doing a water displacement test. Why are you talking to me? Yeah, I was getting to that. That's actually where it's coming right now. So again, with all of these, right, even with, doing Homan sign, you're not diagnosing that the patient has a blood clot. What are you reporting on? You're reporting what you what?
Observe.
Yeah, what you observe, what you see. Because we don't diagnose, right? I'm not going to tell a patient, oh, I think you have a blood clot. I am fancy PTA. No, I'm just saying, hey, I'm worried about this. I want to get it checked out for you, right? I'm not going to diagnose. How are we going to truly diagnose if they have a blood clot is a Doppler ultrasound, right? And we can't do Doppler ultrasounds. That's got to be a radiologist that does that, or an ultrasound tech, I think is what the technical term is for that person. I'm not sure.
Can I emphasize what Mr. McKeever is saying is true? Even the PT cannot diagnose a DVT. All we can do is suspect it, do the test for it, and if we think it could be a possibility, then we call 911 and get them to the ER as soon as possible. But I'm not going to call their doctor and say, me as a PT I'm talking about, I'm not going to call a doctor and say he has a DVT, because I'm making a medical diagnosis which is out of the scope of practice of a DPT.
Yep.
As a DPT, I can make a physical therapy diagnosis, meaning he's having trouble walking and functional things, but I can't diagnose a disease, DVT, claudication, anything like that. I pick up on the signs and refer them back to the doctor so that they can diagnose it. So we have to be careful about, you might do the Homan sign and get a very positive result. And exactly what Mr. McKeever said, you cannot turn to the patient and say, you have a DVT.
Yeah.
You just pretended you were a medical doctor.
Yeah, same thing with if we do like we talked about in anatomy, where we talked about using a tuning fork to see if patients got a fracture, right? We can hit a tuning fork, put it on the bone, and they're like, yeah, ow, ow. We don't go, well, you definitely have a fracture, right? Because again, that's diagnosing. We can report on our suspicions and go, hey, you know what? I'd like to call your doc and see if we can get you in for an x-ray, because I want to get that checked out for you. Right? We don't diagnose. And actually it goes right into what I'm going to talk about down here with compartment syndrome, where a compartment syndrome is where an anatomical compartment like the calf or the forearm or the humeral region results in fluid getting trapped in that area and tightly bound by fascia. And I actually just talked to another PT about this a little while ago. Not the same PT that works in hand therapy, but one that actually one of the PTs I worked with home health called me and says, hey, what do you know about compartment syndrome? Well, it's fluid trapped in a compartment. It's like, well, I've got a patient. What do you think about this? And he's asking me. So I've got their calf's not giving. It's really swollen. It's really hot. It's hurt. It's turning kind of bluish. Am I thinking right with compartment syndrome? I'm like, well, again, we're not diagnosing, but I definitely get them checked out by the doc. So he called the doc. The doc said, send him in the ER. Send him in the ambulance to the ER right now. And sure enough, patient had compartment syndrome, and if it hadn't been observed by the PT, the patient could have lost a limb. Right? So we just report on what we find. When I saw the patient with Cauda-Equina syndrome, I didn't diagnose and go, well, they have Cauda-Equina syndrome. What I looked at it going, man, through all my training, this looks like Cauda-Equina syndrome. Right? And we go by Occam's razor, right? Occam's razor's simplest explanation is usually the best explanation, right? If you're out in the fields here in Nevada and you start hearing hoofbeats, what should you be thinking about? What do you think's coming at you?
Zebras.
Zebras, exactly. There's so many zebras outside Las Vegas, right? Well, actually, if you're down in Pahrump, maybe. But, right, if you hear hoofbeats, think horses, not zebras. Now, if you're on the plains of the Serengeti, is this true, Jason? Is Jason from Pahrump? He'll probably agree with me on that. I've been down there a few times. I've seen some weird animals down there. If you're in the Serengeti, yeah, you might think gazelles or zebras, but you're here in the United States, typically it's horses or buffalo, right? So the simplest explanation is usually the best. If you suspect it, report it to your PT. Let the PT come in, check it again. Oh man, yeah. I think we got something here. Let's get the doc on the phone. Right? And let the doc make the medical diagnosis. That is what they get paid for. Right? That is exactly. When we talk about strokes, even the test we have for stroke, which is FAST, it's not a diagnostic test. It's saying, well, they might be having a stroke. Pain types. Assess not only the site of the treatment, but the patient's overall response, grimacing, gripping. What do they look like? What do we need to know if we're documenting pain in our SOAP notes? Because this is going to come into play in a little bit. This is taking a little longer than I expected. What do we need to have for pain in our SOAP notes?
Location.
Location, 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 right? Just like residential real estate. Good. And also, location, let me say, exact if possible. So if a patient says it's in my shoulder, how do we find out the exact location?
Have them point to the area.
Yep. Can you point to it? It's right there, right? And then Amanda says severity, right? What do we usually ask? How do we ask the severity? On a scale of 0 to 10, with 0 being no pain and 10 being I've got to take you to the hospital and you broke your femur, where are you? Right? Good. Palpate, good. Palpate and view. Dr. Reskin and I really, really like this. If your patient says, I have pain right here and I'm wearing a polo like I'm wearing, what should you do? Ask me to do what?
Ask to lift your polo.
Yeah. Can you roll up my polo and point to it right here? And now, what if I roll up my polo and all of a sudden there's this big, huge black and blue mark that wasn't there before? That's kind of important to know, right? We don't treat clothing, right? We're not Banana Republic. We don't treat clothing. Good. Palpate and view the area. Get it out of the way. Look at it. It tells you a lot about your patient. All right. So we got severity. We got location. Type of pain. Good. What if when you say, "What can you describe your pain to me?" and the patient's like, "I don't know." Can you give them some hints?
Like sharp.
Is it sharp? Is it dull? Is it achy? Is it burning? Is it tingling? What makes the pain worse? And more importantly, what's the other thing?
What makes it better?
Yeah, good. Worse. I'm horrible at writing. This is why I should be a doctor, right? Good. Good. Now you've got a good subjective, right? Is pain normal? Is pain normal? Is it a normal response? It can be, right? And here's the deal. You guys are going to find out once you get to like my age, pain is just kind of a part of life, right? I always have a little achy, painy type thing. Probably even some of you that are younger than me, right? It's not that you're broken. Well, maybe. It's just part of life, right? We're not supposed to be completely pain-free, right? But we're supposed to learn how to live with it. Measure any changes, right? Understand the anatomy and physiology of the patient so you can apply this in your pain assessment. If I say my pain is here, if I'm pointing right here, it's right here and it's kind of throbbing, right? Go, okay, well, patient has pain in their anterior forehead centered between their eyes. That gives me a really good location of it, right? Could be of the brain, but we don't really know. Could just also be my facial muscles here are tight, so we don't know. Got to be careful with that one, Oscar. Right? It's just growing pains, exactly. Okay, referred pain. Is pain felt in an area far from the distant site of the lesion, but usually supplied by the same or adjacent neural segments? Can range in cutaneous, somatic, or visceral source. You guys learned about this last semester with Dr. Johnson, right? If I'm having a heart attack, what's my referred pain look like?
Your left arm.
Right, going down the left arm. Yeah, right. You need to know the brain. Good. Could also go up into my left jaw. But if you're a female, a lot of times they report that they feel like they're having it either an anxiety attack or they feel like they're having indigestion. So we all refer pain a little differently. Visceral pain, pain that originates from the organ. We've all had this at one time or another. If you went to Taco Bell some night, sometimes you'll have visceral pain. Oh my God, I should not have had Taco Bell. It makes me run for the bathroom. right? And it can be a normal condition just because you ate something wrong, but it could also be something bad. It's usually not well localized. It's diffuse and difficult to localize. Trigger points are small tender areas in the skeletal muscle, fascia, tendons, ligaments, periosteum, and pericapsular areas. Can be associated with TMJ dysfunction, temporomandibular joint dysfunction, TMJD or TMD, whatever you want to call it. I joke with patients a lot, say, I've got TMJ. Wow, I've got 2 of them. You only have 1? No, just joking. Don't do that. Right? Temporomandibular dysfunction is pretty painful for patients. Cervical strain, fibromyalgia, traps are a big point of trigger points. We can document trigger points, and we can let the PT know about it. Patients had trigger points in their mid-traps or subscap region, whatever. Radiating pain is usually from a neurological origin. It kind of goes along hand in hand with referred pain, because technically radiating pain is a referred pain syndrome. Patients usually start ignoring the pain. So if I ignore my back long enough and it hurts long enough, eventually I'm going to kind of shut off those pain receptors in my back. But my back is still injured, so my body is going to find a new way to tell me about it. And it's going to send the pain maybe down my butt. If I got sciatica, right? Now it's in my butt. And I ignore that long enough. Now it goes down behind my leg, right? It's usually a sign of pain getting worse, right? Radiation means moving down, right? Or the other term for that is peripheralization. I'm going to butcher the spelling of this, I know. Peripheralization. I'm not going to get through all my exercise today because I wanted to cover this. Versus centralization is good. Peripheralization, bad. Pain moving away from its source. Centralization, pain coming back to the source. I'm sure Dr. O'Neill talked to you guys about this with traction. A lot of times with traction, we'll put them on traction and the patient's like, man, my knee doesn't hurt anymore, but now my back hurts. And we're like, yay! And the patient's like, what? You're a weirdo. My back hurts now. That means the pain is where it was supposed to be in the first place, is no longer radiating. That's a good thing. It means we're getting it back to the original source. We don't judge their reports of pain. I know this is hard because I'm bad at this too, right? Patient's like, I'm at a 10 out of 10. Really? Really? So you're giving birth? Really? Really? You're giving birth with a broken femur? Pain is just assessed and reported as patient reports it. Remember, pain is an objective reporting, meaning a numerical reporting of a subjective feeling. All of us have a different pain level, right? All of us. Dr. Ovreskin has a different pain level than me. Amanda has a different pain level than Dr. Ovreskin. Just remember that. Now, we report pain in the subjective. What if your clinic puts the pain in objective? What should you do? So we've taught you in SOAP notes that pain goes in subjective, but your clinic says, nope, it goes in objective.
Put it in objective.
Put it in objective. Good.
I have a question actually on that too. So
Good.
if your clinic says to put pain like in subjective for the patient telling you subjectively, you know, in the beginning of treatment, your pain is a 7 out of 10, and then after treatment, it decreases. Do you then put that in objective?
Okay, so good. That's actually, we're going to come up with a SOAP notes. That was actually a really good question, and I'll ask Danielle, and I'll answer Danielle in a second. So when the patient reports to you, you know, my pain is a 10 out of 10 when I came in, but after treatment, man, now it's a 4 out of 10. It feels really good. We now have something to assess. So where would we put something that we're assessing?
An assessment.
Yeah, right? Now, that gives us something to report on in assessment. You know, patient's pain decreased today with the prone press-up exercises we gave them, right? We're not going to report, we don't report the number. We already reported the number, right? We can do math. It says 10 first, and now it's a 4. We can subtract and go, it got better by 6. We don't have to report that number, but it gives us an ability to have something to assess out of the treatment session. What if the pain gets worse? Same thing. We have something to assess. So Danielle asked, what do we do if the patients, they say 10, but we know it's not? Well, so first of all, sometimes I will try to explain to a patient that, well, so 10 means I need to take you to the hospital right now. Are you really about, is that really where you're at? Or are you more like a 9 or an 8? And they're like, yeah, probably an 8. Okay. I've got a great comedy video on that. I'll share with you guys then about that. But so that's just where you go. Yeah. Now, what if the patient's like, oh my God, I'm in 10 out of 10 pain. Oh, probably not the best to treat them. Just saying. If they're writhing in pain and like puking all over the place and stuff like that, yeah, it's probably not a good idea to treat them. But some patients will just tell you, I'm in a 10 out of 10. Nope, it is a 10. And at that point, Daniela, you just put patient reports pain 10 out of 10, describe the pain, where it's at, do your normal stuff. Again, it's a subjective finding or subjective feeling. It's how the patient feels, not how we feel. You know, so be aware of that. Just document with your findings without judgment. Vital signs, these are your normal vital signs. I'm not going to go over them because Dr. Sokel is going to hit these with you, or should have hit these soon with you. We should be able to know how to measure vital signs and know their normal ranges. You should be skilled in taking vital signs. Do I need to call an EMT? No, don't say that. It's not a good idea. So I need to call the ambulance right now, huh? Now, I've said that to some patients jokingly, and again, I said, do as I say, don't do as I do. If it takes you 20 minutes to take vital signs, it's taking you too long. You got to get quick at this, right? I do my vital signs while I'm getting all my subjective information from my patient. So while I'm getting my pain, I'm taking blood pressure. While I'm getting the reports of my pain, I'm taking pulse ox. I'm doing all of that while I'm doing stuff. Now, it does take a little bit to get that skill, but you need to get vital signs down quick. It needs to be 2-3 minutes tops to get vital signs. So if it's taking you 20 minutes, that's 20 minutes you don't have for treatment. It needs to be rapid, boom, boom, in and out. So it means you got to practice it. And your CIs will get frustrated with you if it takes you 30 minutes to get vital signs. I'm just saying. Fatigue is, normal for people, right? Observe and report abnormal response stuff. It's abnormally fatigued, report it. I am abnormally fatigued today. I am not my normal self. My PASC is kicked up today. Like I just did not want to move today. Right? Cardiopulmonary fatigue, dyspnea, shortness of breath, chest pain, any of that we've got to pay attention to. You can measure it on the RPE or the rate of perceived exertion scale or the dyspnea scale. And we'll go over those as we go through this. Range of motion, we already covered a little bit in kinese, right? Just remember that range of motion is joint motion, while flexibility is muscle motion, right? So when you're doing this, we will use goniometric measurements to kind of measure a little bit of both, but the muscle, the flexibility is more dealing with that muscle movement. Fracture, I know the signs and symptoms of a fracture. Pain is a really good sign of a fracture. Patient may have point tenderness. And fractures get missed a lot, just to let you know. Joint capsule, we'll talk about this when we talked about joint mobilizations. We've talked about roll, spin, and glide already. I'm not going to cover them again. Distraction, compression, pretty simple on that. Be aware that distraction is a joint mobilization. And what do we know about joint mobilizations as PTAs? What does the APTA say about joint mobilizations?
Do it.
That we can't do them.
Very good, right? That we can't do them. I am going to warn you about distraction, meaning actually pulling on patients, like doing distraction with especially the spine. I don't even do that. And I'm pretty skilled. And most clinics will say that PTAs do not do spinal distraction. You can put them on the traction machine, but you're not skilled enough to assess the ability to do spinal traction manually. And I actually agree with that 100%. I do not argue that in the least. I am not skilled enough to know when I'm damaging a facet and when I'm not damaging a facet. And I challenge sometimes even PTs knowing that certain times. So be aware of that. Protect yourself, right? Patients, PTA's role is to report anything that we see. Ligamentous laxity, we deal with this a lot with patients that have stuff like muscular dystrophy or cerebral palsy. This is where joints are really, really loose and kind of lackadaisical, and they don't provide that nice joint stability. Patients a lot of times will say, my knee gives out when I walk. That's a sign of ligamentous laxity. If they have ligamentous laxity and then suddenly have heat, pain, and edema, that's a problem. Report it immediately to PT. So if they're like, My knee gave out when I walked, and you look down at that knee and all of a sudden it's red, angry, and swollen, get the PT. That means something might have happened in there that could be dangerous to the patient. So get that PT. Gait and balance, we're going to go over this in depth. So we're just going to hit this really briefly. The RLA is the neurological components of gait. Traditional is the musculoskeletal components of gait. We'll cover those in depth, so don't totally worry about that. Deviations, we always report. Anything we see in gait deviations, we're going to report. But you can't report deviations unless you're doing it on a surface you can measure gait. So nice flat surface. Balance. We must become competent in performing balance coordination and agility training, right? Vestibular, knowing if it's an ear, if it's problems with muscles. We have a whole lesson on balance, which will get fun. That'll get really, really challenging. Balance and challenging. See what I did there? Last thing I want to cover today, SOAP notes. How many of you guys are worried about SOAP notes? I've had some conversations with some of you already about it, but how many of you are you worried about SOAPs?
Me.
Good.
Yeah.
Okay, good. Guess what we're going to do a lot of this semester? SOAP notes, right? Good. It's good to admit that, Anthony. Anthony says I am because I'm too slow. That's a good thing to admit because you know you have an issue with it, right? We just got to work on that. I am really, really, really bad at writing SOAP notes, like actually physically writing. God, it takes me so long to write. I can type, I type 100, 120 words a minute. Give me a computer and I'm like, I'm done. Right? But if I have to write a SOAP note, it takes me for freaking ever. So we're going to give you, they're actually in your TherEx and actually I think in your Kines, if I remember, put them both in there. They're examples of SOAP notes. Right, John put a thing. What's too much info versus not enough info? It's always a little better to have too much. Not enough is not good, right? If you put something like patient tolerated treatment well, what does that tell me? Does that really tell me anything?
No.
Patient tolerated treatment well. Right? Continue treatment as per plan of care in a plan. Okay, nothing to change? Nothing to add? Right? Patient reported pain today in subjective. I love that. That doesn't tell me anything, right? We've got to have, there's got to be some quantifications and qualifications to everything we type. So we're going to work on SOAP notes. I just want to promise you guys that, right? But one thing you have to understand is you guys are going to have to work at this. This is not an easy skill. This is not an intuitive skill. It takes you a little bit to get better at it, right? I liken this to playing a sport. SOAP notes is your sport right now. You don't get better at SOAP notes without practice. And one of the things that we try to work on, and Dr. Reskin will really work on it with you, is working on these SOAP notes so that so it's tailored so your CIs are happy with your SOAP notes. But the one thing you want to make sure of is you're not taking till 9 o'clock at night to write SOAP notes. Because one of two things, or a couple of things here. If you're spending till 9 o'clock writing SOAP notes, number one, you're losing personal time. And that's not good. You have to have a life balance. The other thing is, if you're in the clinic till 9 o'clock, who else has to be in the clinic till 9 o'clock?
PT.
Yeah, the PT or the CI. And that is a quick way to not endear yourself to your PT or PTA. Now, we understand the first couple SOAP notes you write are going to be slower. We understand that, right? CIs do understand that. We understand you are not fully trained clinicians, right? But it's our job then to help you get better at it and get quicker at it. So, if you get mad at us because we're helping you with your SOAP notes, don't. It literally is making you a better clinician in the end. Remember that if Dr. Reskin or I or Dr. O'Neill or Dr. Sokel or your CI gives you feedback, we are not attacking you, right? Please don't ever think I'm attacking you or your CI is attacking you. They're not. Their goal is to get you better, right? If you ever think I'm attacking you, come talk to me about it. I'm not, I promise. I don't attack, right? The only time I attack is when I'm playing Destiny. That's the only time I attack. So we're going to work through these things. A good SOAP note is really important. And we're going to work on doing some electronic documentation too through WebPT. Dr. Ressa, do you have anything you wanted to add about SOAP notes? I know that this is a constant battle.
I like what you said about let CIs understand that when you get into the clinic, it's going to take a student, you know, a week or two to adjust to the style of soap note that they expect at their facility. Every facility has different structure and requirements for their soap notes. But what you want to do is every day get better and show that you are improving in a gradual but consistent manner, because some of the complaints that I get from some CIs, and this doesn't happen very often, but once in a while they'll say, I've been giving the student a lot of feedback about their soap notes, but nothing has gotten better. And so if you can just incorporate one new thing or do it 1 minute faster each day, that will show them that you are putting, you know, you're focusing on getting better, and that you're trying and you're motivated, and that to them, that means you're a good clinician. Someone who's not getting better and is not incorporating their feedback means to them that you're not interested in learning, and that equates to not being a very good clinician. So they don't expect you to go from 50% to perfect. They just expect to see 50% the first week, 55% the next week, and just keep improving every week.
That's excellent. One of the things I did when I was on a clinician, when I went on my first long-term clinical, is I told my CI, I said, during the first week, I want to really get good at doing my subjective. During the second week, I want to get really good at doing my objective. On the third week, I was working on assessment. On the fourth week, I was working on my plan. So that I had a goal that first week, man, I want him to beat me down with my subjective, get me good at doing subjective, right? And then, okay, the second week, we were really hitting that objective, making sure that was fine-tuned. I had a plan myself on how I wanted to improve. And that really shows initiative, right? I had a plan when I came into working at the clinic that had ICUs, that I wanted in those ICUs. I wanted to manage those lines. I wanted to figure it out. It was terrifying, but I had a plan. Right? And the PTs like it when you say, especially, I love it when my students say, you know what, I really didn't do the best today on those objectives. I'm going to work on that tonight, and tomorrow I'm going to be better at it. I really like that. That means you're invested in your own self, right? And I'm invested in you, and CIs are invested in you. Dr. Ovreskin's invested in you. Dr. Sokel's invested in you. Dr. O'Neill's invested in you. You'll eventually meet Mr. Gersh, who's on one of our other PTAs. He's invested in you. All right, that is it for this lesson. Ooh, that took a long time. Why don't we do this? Let's take a 15 here. So it's now about 20 after, so let's come back at 35 after. Put on some shorts and t-shirt, tank tops. I'm gonna try to watch as much as I can from you guys, but I'm gonna be demonstrating. So there is, I wanna bring this up really quick just so you can see it. There is this part of the lecture up, or not lecture, but this part on the Blackboard. If you could download this on your break, this has your foundational clinical TherEx in it. We're going to go through each of these. If we don't get through them all today, we will finish them on Thursday. So take a 15-minute break, get some shorts on, and we'll practice. I'm going to pause the recording. So we're back, we're going to start recording here again. We're going to talk in a little bit when we get through exercise concepts. We've kind of already covered concentric, eccentric, isometric, isokinetic, right? Some of the first exercises we're going to do with patients, especially when we're in the inpatient setting, are going to be isometric exercises. Because isometric exercises help build what in the muscles?
Strength.
What's that?
Strength.
Strength, good, okay. More importantly, they help build stability, right? We're going to talk when we have patients that have like rotator cuff repairs. We're going to be doing a lot of isometrics with them because it helps build up that stability in that shoulder that they're missing, right? If you have a rotator cuff repair, your shoulder is inherently unstable. So we're going to start with those isometrics. So what I did when I designed these is kind of started at the basic isometrics, then we're going to work down through some of the more basic exercises. I hate to use basic. Fundamental is the better term for this. So I'm going to switch cameras here. All right, I'm getting my chair out of the way. Go over there, Snaky. Hang out over the cord's in the way. Hold on 1 second. Gosh darn it, my fan's in the way of Snaky getting out of my way. There we go.
So I can kind of visually check on people,
Cool, thank you. As they're going through.
give feedback.
Yep. So I'm gonna come to, if I'm down here, I did test it earlier. You guys should still be able to hear me, yes?
Yes.
Cool. I turned up the gain on my mic. So one of the first things I did before we even get into exercises here, patients say, I don't have the tools around my house to exercise. Do you ever have a friend say that or hear somebody say that? I don't have the tools around my house. So I just went around my house and grabbed some things that I can use to exercise with. I have that I can use for stretching, right? I can use a belt for a lot of things to help me out. This is nothing more than a piece off my Swiffer. Oh, I'm over here. That's right. Right? This is just a piece off my Swiffer. I can use that for certain exercises. I don't have any weights. Well, if you have an Essentials of Musculoskeletal Care book, you don't need any weights, right? Your rehab book, you no longer need weights because that rehab book's pretty heavy, right? I've got some simple weights. Or we can do stuff as simple as sending them home with some TheraBand. I had to find this. I didn't know where it was. It was floating around my house. We can send them home with some TheraBand. Remember that your TheraBand has a progression, right? And when we talk TheraBand, we're usually talking the true TheraBand. This is true TheraBand, like made by TheraBand. There are off brands that make TheraBand as well. But when we're talking true TheraBand, what is the lowest level of TheraBand? Water bottles. Good. Yep. Good job, Dr. Ruskin.
Yellow color?
Orange.
Yeah. Yellow or orange-ish. Again, it depends upon the brand, but when we're talking true, your true TheraBand, yellow is low, right? That's the basic. And honestly, when we get back to the clinic, you'll see yellow band is like ridiculously easy to use, right? From yellow, they go to where?
Orange.
Orange, well, okay, depend again. Orange again or reddish, right? Some of us are going red. Yep, there we go. Good, Stephanie. Red, the next color is what?
Green.
Green.
Good. Now, I always think that when I get into green, my patient's getting to go level, right? Because green's starting to provide a little bit of significant resistance. Then we go to my favorite here, which is my color that I like, blue, right? Now, there are two levels above blue in TheraBand. There is gold and there is black, right? Gold is a kind of middle between that blue and the black. I've very rarely seen gold. And honestly, in all the clinics I have been in, the black roll is just sitting there completely unused because patients don't get the black typically, right? So, I mean, it does not mean that he can't, but there, I've got TheraBand. You've got stuff around your house you can use. It doesn't mean you have to have anything fancy. I don't even have any weights in my house. I've got body weight I can do exercise with, right? I can do body weight resistance. Dr. Reskin said water bottles provide resistance. There's all kinds of things you can use. The nice part about water bottle, you can then freeze it and use it as a cold pack too, right? So there's all kinds of stuff that you guys can use. So we're gonna start off with abdominal bracing. When we talk abdominal bracing, there are two things I wanna hit here. There's abdominal bracing and there's drawing in. So I'm gonna lay on my back here and I actually position my camera so I could, right? Abdominal bracing, what muscles am I working to use?
Transverse abdominis.
Transversus abdominis, and unfortunately, I cannot isolate and stop rectus from firing, right? Rectus is just kind of dominant ab muscle, along with our what's? The muscles that go like,
Internal obliques.
yeah, external, internal obliques, right? So that, I'm like, why is my head low? There we go, that's better. So when I'm doing abdominal bracing, my goal is to get that TRA or the TVA, transversus abdominis, to fire. That is the girdle of my core. It helps me keep everything nice and tight, right? It helps keep my back in line and keep that lordotic curve in there. So when you're palpating on a patient and you're thinking, okay, well, they're going to start abdominal bracing, where would you want to palpate on them? Well, right here in the belly, right? I'm going to place my hand on either side of your belly button and we're going to practice this. So what kind of verbal cueing do you want to use?
Hey, Mr. McKeever, do you want everyone doing it in sitting or have them lie down?
Well, whatever works, because I know some of them want to keep their cameras on them, so I can understand if they're going to sit in sitting. I'm doing it in supine because you can actually see a little bit better. I'm just trying to be modest too as well. So what kind of cues am I going to give a patient? What do you think abdominal bracing means to do? Anyone have any?
I usually tell them just like give me a laughter and feel that contraction, just kind of hold it.
Good. So we're gonna take, and I'm gonna tell them, okay, what I want you to do is I want to tighten your belly down, right? I want you to feel that kind of that girdle tighten up. And just doing that, like my back already just fired off doing that's fantastic. Right? So that's true abdominal bracing, is just getting that. That is an isometric hold. I'm not doing this. Or whatever the weird things patients do. They're just tightening their belly muscles. And we're gonna hold. It's an isometric, so they're gonna hold. 5, 4, 3, 2, 1, and relax. So everyone do that. Put your hands on your belly for me. Right? Feel that nice transverse abdominis going across your belly. Tighten your belly down and hold. 5, 4, 3, 2, 1, and relax. So when we document that, we're going to document if there's a hold, how many sets they're doing. Sets are groups of reps. Honestly, in the clinic, unfortunately, we have this habit we get in the clinic of picking numbers out of the blue. So we'll say, well, you're going to do 3 sets of 10, right? We're going to do 3 sets of 20. We just make sure that we document what they're doing with a 5-second hold. Again, when we have an isometric, there has to be a hold there. Isometric meaning no length changing. There we go, I can speak, right? Isometric. Now, there is a modification to abdominal bracing called drawing in. And with drawing in, same idea. You're going to tighten your belly, but you're going to tell the patient, I want you to pull your belly button back to your spine. So I'm going to lay here, I'm going to tighten my belly, and I'll pull my belly button back to my spine. And I want you guys to do that. So put your hands on your belly, feel the transverse abdominis, tighten it, and then pull your belly button back to your spine. Does that feel a little different? Maybe feel a little bit more down in the crest of your pelvis when you do that, as everything kind of tightens up. Yeah, right? Remember that when we're doing this, if I'm laying on my back, and well, you guys are, some of you are sitting up if you're doing it, is gravity helping me or resisting me if I'm laying on my back?
Helping.
Helping. Good, right? So that means I'm not an against gravity exercise. So with abdominal bracing, if I'm doing this here, gravity's helping me. How can I change this to add gravity to make it more challenging?
Like a sit-up?
Okay, well now you're changing the exercise. Let's keep the same exercise.
You could be on all fours.
Good, right? I could go on all fours, or even if I can't get on all fours, I can just lay here. Now gravity itself is pushing my belly down, right? If the patient can't get up on all fours. Up on all fours is a good progression for it. Don't get me wrong. I'm not saying it's wrong, right? But the patient has to be able to get up on all fours, right? Or all threes. Maybe they have an amputation. So don't be totally restrictive on that, right? But I can do that here in all fours, right? I can modify this and I can draw up on all fours. I can do it in sitting. I can just sit here, tighten my belly like some of you guys are doing. Okay, take a deep breath, in and out, and tighten that belly down. Why is that important that I can do it in sitting? Well, it's because what if you have a patient who works in the office, right? Should they take breaks? How often should they take a break if they're working in an office?
15 to 30 minutes.
Okay, that'd be ideal. That'd be really good. At least every hour. Yeah, right. At least every hour, move around a little bit, right? And I think that's what I have an Apple Watch here. Yay, I'm fancy. I'm part of Apple. It tells me about every hour to stand up. Thanks, watch. Right? But it does help. It can help people like that. But I can do these exercises and not have to stand up, but at least I'm doing something. So abdominal bracing, tightening that TRA. The next one is glute sets. What do you think we're going to tighten up with this?
Glutes.
Yeah, the glutes, right? The buttocks, as what's his name? Forrest Gump would say, right?
Or we call it hips.
Or hips, good, right? So the main idea here is we're firing off kind of all of the, it's really hard with the glutes to actually isolate, especially if you're gonna say, oh, I'm gonna isolate gluteus minimus. No, you're not. You're not, right? You're gonna kind of get all the glutes at once. So this is important because when you're palpating, right? If I'm like, okay, I'm gonna palpate. No, right? But I can come out here and be on glute medius and still get the glutes. We're not gonna grab people by their bottoms is what I'm saying, right? You gotta be aware of that. So you guys are in sitting, I'm gonna lay down again just because I need a nap. So I prefer to do these in hook line. I do most of my isometrics in hook line. So what are we gonna tell the patient to do you think, for a glute set? What do you think?
Squeeze.
Okay, squeeze your bottom together, or squeeze your hips together. And again, because it's a set, it's an isometric. So they're gonna do what?
Hold.
Hold. What if they can't hold for 5 seconds?
Then hold for 3 seconds.
Good, right? Hold for 3 seconds and work your way up to 5. We're gonna talk about that with Kegels as well. If they can't do 5, do 3. Work your way up. So put your hands kind of on either side of your, where you know your glute needs and maybe a little bit of your glute max starts, right? And again, with this one, we're not doing any funky movement. It's not like we're gyrating our hips around. We're just gonna tighten our buttocks down. A lot of time, your back will kind of close off and get a little bit more arch with it. And you're gonna hold. So we're gonna put your hands there, feel those muscles, tighten your glutes and hold. 5, 4, 3, 2, 1. And ironically, when I did ab sets there, my back hurts. But when I do the glute sets, my back feels a little bit better. I actually don't mind this. This actually feels good on my low back. 3, 2, 1. What happens if we pick a patient and they're like, we're gonna do 3 sets of 10, and the patient gets to 10 and they're exhausted? Well, we start with what they can do. Right? Don't be picky and choosy about that. Let the patient know that it's okay. Most of them are injured. You guys are doing this and you're like, this is simple stuff. Some of you are like, I squeeze my butt cheeks together and I haven't used those muscles in years. Looking at you, John. Right? So glute sets, we're tightening up those hip muscles, especially those hip extensor muscles in the back, that big glute max fat that we have back there. Hammy sets or hamstring sets. Now we get a little bit different. This is one that's kind of hard for a patient to grasp. So what's the job of the hamstring? What's its main job?
Flex the knee.
Flex the knee, right? Bend the knee back. But again, with the ham set, we're doing an isometric activity. So what I often tell patients to do is, you can do it in sitting if you want, or you can do it in hook lying. I'm gonna dig my heels in. So I'm gonna do them bilaterally right now. I'm gonna push my heels and pull back like I'm bending my knees. Right now, my hand knees are firing like crazy. So I'm kind of driving my heel into the floor or into the mat. I'm on a floor, I don't have a mat, unfortunately. Matt's, I think.
Mr. McKeever,
Yes.
can you rotate 90 degrees to the left? Yeah.
There we
So
go.
profile, thanks.
No problem. Thank you for cueing me on that. I can't see my, close my drawer so I can see a little better, right? So I'm digging my heels in. I'm making like I'm doing a bending of the knee, but I'm not actually gonna move. I'm gonna fire those hammies. 5, 4, 3, 2, 1, and relax. I can do the same thing in sitting if I was up like you guys are, right? And sit, I'm sitting here, I can do the same thing and fire backwards. 5, 4, 3, 2, 1. Ow, that actually hurt. Ham sets, pulling back on that hamstring. There's not going to be a motion because, again, with a set, we're doing an isometric activity. Where are you going to palpate for this?
Hamstrings.
What's that?
The hamstrings.
Yeah, so you're going to palpate back here in the hamstrings, right? So get back here and get on their hammies. You can come down here on the distal portion. I kind of tend to get up in the kind of mid portion of it. I'm not all the way up here on the butt again, right? I'm on the hamstring. This is important when you're doing this. You need to get hands-on, especially the first time you do these exercises, because you need to make sure that if I'm doing a hamstring exercise, I'm not firing my quads, right? It's important to palpate. Big hands again. I'm not going to palpate my hamstrings with these two fingers. I'm over here again. I have too many cameras in my house. Now that's pointy, pokey, right? We leave pokey with Gumby again, and we do big hands onto the hamstring, find the hamstring. That was why it was important in anatomy to learn your muscles and bones and attachments. All right, so we did abdominal bracing, glute set, ham sets. Well, if we did a ham set, the next one we're going to do is a quad set. Good. What type of patient do you think the ham sets and the quad sets are really good for?
After knee surgery?
Knee surgeries, yeah. Right? Especially knee surgeries where the doc says, no isotonic activity for these patients. So no concentric or eccentric contractions. They're only allowed isometric stuff. They can still exercise right here as long as it's part of the protocol. So I'm going to lay down 90 degrees again. Okay, so quad set, we know what's the quad's main job.
Extension of the knee.
Extension, extension, extension. Good. So there's a couple of cues you can do here. Obviously, when I'm palpating this one, I usually put my hands underneath the patient's popliteal fossa. That way I can feel the knees kind of go down. There's going to be a little movement, but then an isometric hold. You could also take something like another pillow and put it under their legs so that when they push down, that pillow gets a little squished. That was a little sharper than I expected. But the main goal here is you're going to tell them, I want you to straighten your knees and push your knees down into the mat. And you're going to hold when they're as straight as possible. So I'm going to tell them push down and hold. Again, you're looking, you can palpate behind the knees. The main muscles you're going to palpate are those quads. 5, 4, 3, 2, 1. And relax. And we're going to do that again. So everyone squeeze down, straighten the knee out. 5, 4, 3, 2, 1. Relax. Again, with that one, gravity is assisting me, right? Because gravity is helping push my knees down. I could do it in prone to add a little bit of gravity resistance if I wanted. Very little, but some. You can do it in sitting as well if I straighten my knee out and do the same thing and just push down. 5, 4, 3, 2, 1. The main thing you want to watch for is they're not doing kind of rotational movement with the legs, right? We're looking for substitution. The quad. It is just mainly the quad. I don't worry too much about the feet right off the bat. I see that question from Brooke. I'm more worried about just getting this quad firing, getting that firing down, seeing that vastus medialis oblique, pulling the kneecap into right position, and firing that quad down. 5, 4, 3, 2, 1. The space under the kneecap or under the patella should close off. The knee should come down, which is important in the hospital setting because one of the things we learn when we get knee patients is the number one thing they lose is knee extension. And a lot of the studies show we can get flexion back years down the road, well, not years, months down the road. But if they lose knee extension, it's really hard to get it back later on down the road. I have a family member right now who had bilateral knee replacements and they didn't work on extension. She's now 2 years out and she's stuck at 35 degrees. So she's constantly at about a 35-degree flex. And no amount of stretching I've tried, like putting weight on her knees, stretching her, it's just she's locked there. So you don't want to put your patient. Quad sets are really easy exercises. All of these exercises I give my inpatient my hospital patients. There we go. I'll just say that. I give these exercises to do every session between sessions. So I tell them, I want you to do glute sets, ham sets, and quad sets 3 times a day for 5 reps and hold for 5 seconds each. Well, I don't have any time to do this. I'm really busy here at the hospital, you know, counting the ceiling tiles. So what could you do to help a patient remember to do them? Because remember, adherence is about remembering to do it.
Can you, I don't know if this is allowed, but a lot of rooms have whiteboards. Can you write it for them?
Good. There's a good way to remember it, right? Write your exercise. You got to do these 3 times a day. I like to use TV because a lot of them are just sitting there watching TV. So I'll tell them, okay, so I know Judge Judy is really important, but the ads aren't important. So when the ads come on, I want you to pick one of your exercises and do them. Right? And then the other thing I use, again, I told you this before, is I use kids. I know their grandchild's in there, or you know, their son or daughter. I'm like, all right, mom and dad's got to do these 3 times a day. I'm going to come back tomorrow. Can you let me know if they've done them? Good, I got a little spy. Right? And they can do these too. Would these exercises hurt a kid? No, right? They can get up on the bed beside grandma as long as it's allowed and do these. Well, that was pre-COVID. Now we're in trouble, but. All right, so are the first 4 fairly clear? Abdominal sets, right? Tightening that belly down. Glute sets, tighten those big hip muscles. Ham sets, the knee flexors tightening down. Quad sets, hitting those quads hard.
Did you say for knee patients you do glutes, hams, and quads, or is it mostly just okay?
No, and I actually add abdominal bracing too sometimes, because abdominal bracing really helps with getting that belly nice and tight. And honestly, most of the patients we see, one of their weakest areas is, what do you think? Their core, right? How many of you guys are willing to admit that your core is kind of weak? Not me, actually, I'm not going to admit to that. My core is probably the strongest part of my body. So you do as many sit-ups as I do, it should be. All right, so adduction squeezes. And again, notice it says add adduction squeeze, not abduction squeeze. So what are we doing to the legs? We're doing what? Closing them off, right? We're closing that together. I always love doing this at the gym because they have those machines that you can do that. The adduction machine. And there's like no guys that ever do those machines, ever, pretty much, at least in my gym. They just kind of sit over there by themselves. Joe does good. I'm proud of it, right? It's a good finisher for leg day. You're 100% right, Truman, right? And so when you're doing those, it's just, and somebody walks over and you're like, oh my God, you're actually using that machine? Yeah, it's good for your legs. So you can use a pillow. I don't have any balls, but honestly, when I'm doing these patients, especially if I'm doing home health, I keep a bunch of those like $3.99 Albertsons plastic balls in the back of my truck. You know what I'm talking about? Yeah. Who was it? Anthony? He's got one of those, right? Just those cheapy kid balls. The basketball works well. It's just a little more resistance. But I keep a handful of those in the back of my truck because a lot of times patients don't have something, but a pillow works just as well. So they're going to lie on their back. Preferably, you can do it in sitting as well. I'll show that in sitting as well. I'm going to take my pillow or my object I'm going to squeeze, and I'm going to place it between my knees. So what are you going to tell the patient to do now?
Squeeze them together.
Squeeze your knees together, right? Good. So we're going to take, and I usually have them put their feet, if you can see my feet, they're just a little bit apart. And I'm going to squeeze that pillow hard. 5, 4, 3, 2, 1. Now, is there a little isotonic contraction going on here? Yeah, right? There's a little concentric contraction going on. And eventually it kind of leads to an isometric hold. 5, 4, 3, 2, 1. What if I don't have a pillow? Well, if I'm in sitting, I can put my hands there, right? But I guarantee we all have something we can use for this, right? We all have pillows laying around our house. This is my
Towel roll.
pillow. What's that?
Towel roll.
Towel roll. Thank you. There we go. That's what I I was drawing a blank. Thank you. I appreciate it. I was like, what was I thinking? Towel works well, right? Again, what if I make the pillow wider, right? That increases that concentric contraction. But what if the concentric contraction is not what I'm going for? I'm just going for that isometric. So a thin pillow is just fine. The main goal of what you're putting between the knees, thigh master, exactly. The main point of what I'm putting between my knees is so that my knees aren't doing this, right? That hurts. Because I'm banging those two big medial epicondyles against each other. This keeps that from happening. Now I can squeeze it, right? What muscles am I working?
Adductors.
Adductors, good, right? Are there any other kind of, so we got our adductor magnus, right? And our adductor longus, a little bit of gracilis, good.
Pectineus.
Right. What's that?
Pectineus.
A little bit of pectineus, good. See, you learned something in anatomy. Give yourselves a round of applause. No, no one, okay. That was a funny joke. I don't care what you say. You're gonna squeeze it together, right? Now, what happens if I take a basketball like Anthony had and put that there? What is that going to increase?
The space between.
Space between the knees, and it's also going to increase the resistance, right? That basketball is usually pretty inflated. He's out there shooting hoops with it every day. I see him in the, no, I don't actually see him anywhere, right? But that's a pretty heavy resistance. So you've got to watch that. Like, especially I've seen people where they'll get the heavy medicine balls and they'll use those. Those medicine balls are pretty thick. The goal is not to have them squeezing something hard. The goal is to get a nice isometric hold. Again, we're trying to get a kind of a rebuilding, restabilization of the hip joint. I'm going to talk in a few weeks about some surgical precautions. But does anyone know of a particular surgery we might want to not have do the adduction squeeze? Anyone have an idea what surgery might happen that we might say we're not going to do this?
Total hip.
A hip replacement?
A specific total hip, a posterior total hip replacement. Because one of the precautions for that posterior total hip is no adduction, no crossing the legs, right? And so if we're doing this, we just told them to do what we told them not to do, right? So we've got to be careful with that. Right now, is it going to pop the hip out immediately? Probably not. But again, it's all about maintaining compliance. And if we tell them to do an exercise that violates one of their precautions, we're not reinforcing the precautions. So you've got to be understanding of what your precautions are. All right. So adduction squeezes, ankle pumps, or what I call the gas pedals. This is really good for a lot of patients. The other thing this is good for is flying. Because what do ankle pumps help do? They help keep that blood from sitting in your calves while you're sitting on that airplane for the whole ride, especially if you're somebody that's at risk. Myself, because of my heart condition I have, I'm at risk. I have AFib, right? Because I have AFib, I'm at high risk for blood clots. Sitting on a plane for 8 hours, flying across country like I'm going to do in a few next week, I've got to make sure that I don't get a blood clot in my calves. Ankle pumps are a way to do that. So again, I'm thinking hospital-wise here. Patient's going to lie on their back. What are you going to tell them to do? We're going to pump those ankles.
Like bring your toes towards you and away from you?
Yeah, there we go. Pull your toes to your nose and push down on a gas pedal. Toes to your nose, gas pedal. You can add an isometric hold in each direction, right? So I can say, okay, pull up, 5, 4, 3, 2, 1. Push down, 5, 4, 3, 2, 1. Right? So let's review muscles here. When I'm pulling up, what's my main muscle pulling me up in a dorsiflexion?
Tibialis.
Your TA. What about pushing down?
Gastroc.
Gastroc.
Gastroc, right? Or the other way to remember that is, I don't know if you've ever heard the term, but your triceps surae. So your sural region is this bottom part of your leg, right? So triceps, 3-headed, surae, lower part of your leg. What would be the third head that goes along with the 2 heads of the gastroc?
Soleus.
Soleus, good. right? So if I've got my legs straight, I'm kind of doing a combo breaker of all of those. So the triceps when I'm pushing down. Does anyone know how I could isolate it and maybe primarily work a little bit more soleus?
Bend the knee.
Good thinking, right? Because what's the gastroc? How many joint muscle is the gastroc? 2, right? Knee, ankle, right? But I can bend the knee. Now I put that gastroc on a little bit of slack. And now when I push down, I'm doing a little bit more soleus. But we know, what do we know about the soleus?
It only does plantar flexion.
Okay, it only does plantar flexion. Good. What else?
Smaller, it's deeper than the gastroc.
Good. And it's also the strongest muscle by volume in the human body, right? By volume, meaning the size of it and everything like that. So what do you think? Do we really need as much work on that as maybe as we need on the gastrocs? Probably not. Unless the PT identifies, hey, they've got some serious problems with the soleus, then we do. But for the most part, not. I can do it sitting. I'm going to turn my chair around, actually. I should have done that. Come on, Sneaky, turn around. I can do ankle pumps and seated, right? Now I'm on the airplane. I'm flying over to Virginia next week. I can do ankle pumps here and seated, right? You guys can do that when you're sitting listening to me drone on all day long. All of these muscles that I just give, could you do these during the session when you're sitting here listening to me? And would I even know it really? Probably not. I mean, unless I see you like, then I know you're doing it, right? Glute sets. Shouldn't be moving that much with glute sets, I'm just saying. So we got ankle pumps. Okay, the next one we have is what I call ankle rotations, but in reality, it's not an ankle rotation, it's a hip rotation. I call these wig wags with my patients. So this is where you're gonna go internal and external rotation with the hip. So I'm just gonna sweep the leg out, sweep them in, out, in. I've heard these called windshield washers, wig wags, ankle rotations, but remember, I'm not really rotating the ankle. All that motion is occurring up here in the hip. I may get a little eversion and inversion going on, and you can notice I have almost no internal rotation on my hips. I'm too tight. So I can just sit here and wag them in and out. So let's practice that. I'm going to do it up here and seated because I know a lot of you are. I can put my legs out in front of me, in, bring my toes in and out. And if you notice, my ankle's not doing a lot of work. You also notice that I have a contraction into extension of my toes. In and out, in and out. How many of you guys does that bug a little bit? Does that bug your hips a little bit? Anyone? No, for me, my hips are really, especially when I go into that internal rotation, my hips are saying, nope, it's not happening. Come on, internal, turn. I am really tight in internal rotation. External rotation, I'm fine. I walk like that. So again, multiple things. So with that, because that's the rotators of the hip, this is where it gets a little picky on your boards. Your boards aren't going to specifically, I'm going to get where I can see you guys. Your boards aren't going to specifically say, give me the rotators of the hips. But what are some rotators of the hips?
Piriformis.
Piriformis, good, okay.
Gluteus medius.
A little bit of gluteus medius, good.
Sartorius.
Trace does a little bit, good, all right. You guys remember the gemellus group?
We didn't get taught that, really.
Well, you know, I know he covered it. He just said you didn't have to memorize them, right? There's gemellus superior and inferior, or what we usually just call is the deep rotators of the hip, right? But the main one, what one do you think causes a lot of problems with patients? Piriformis, right? The piriformis is back here on the back side, is that kind of long, broad muscle. What passes under the piriformis from anatomy?
Sciatic nerve.
Sciatic nerve, good, right? And so sometimes if you give these little hip rotations, patients are like, oh, that really, when I turn in, man, I'm getting zinging down the back of my leg. That's something to report to the PT, right? Because that means the piriformis is kind of cinching down on that sciatic. So we got our ankle rotations. Supine hip abduction slides. Supine hip abduction slides. All that means is we're going to lay on our back again. We're going to straighten our legs out. And we're going to pick a leg. I'm going to pick my right leg here. And I'm going to bring the leg out to the side. Oh, let's try the left leg. I have more space over there. Bring the leg out to the side and bring it back in. Out to the side and back in. Out to the side and back in. This one, I have definitely heard some PTs refer to this as washing the windows. So it looks like a windshield wiper, right? I can do one leg. I can do the other leg. I can alternate. I will say that most patients, it's usually better to do one leg at a time because that way they don't get confused. What's my main muscle doing that?
TFL?
Gluteus medius?
TFL.
Gluteus medius and TFL. Good, right? Now remember, TFL, how big is that one?
Tiny.
It's tiny muscle, right? The main job of the TFL is exactly like it says. Tensor fasciae latae. Tenses the lateral fascia. Make sense? Oh, I just saw Anthony's like, oh, it makes a little more sense now. The main job of TFL is to tighten up that whole lateral compartment of the leg. But it all attaches and works the same, right? But your glute med is one of the main ones. We're going to talk about that with a specific type of gait called glute med gait, where that hip drops because the glute med is weak, otherwise known as Trendelenburg. So we can do that in seated again. So let's try that in seated for all of you. Legs out straight in front of you. We'll start with the right leg. Slide it out to the right 5 times. 2, 3, 4, 5. Good. Let's even ourselves out and do the left side this time. 1, 2, 3, 4, 5. I'm leaving marks in my carpet. That's hilarious. Now, what happens if that's difficult for a patient? How could you make that a little easier?
Lying down might help.
Lying down might help. Good, right? But what if the problem is friction? What if the problem is friction?
Put a towel.
Ow, right? So I can go over here. I already was kind of prepared for this, right? I can put this towel down, which is a nice smooth surface. I don't care if the towel slides with the foot. I'm not putting a lot of pressure down, so it's not staying, right?
Use a disc slider.
Good, a disc slider. I don't have any of those. Those are at the school, actually. I was thinking about that. We also have a thing called a powder board in the hospital. So powder boards are really expensive boards that they can buy that you sprinkle, used to be talc powder. I don't know what the replacement for talc is now, but basically baby powder. And that smooths the surface out so they can put the board under their foot and they can slide out to the side and in. It's like a slide board, exactly, right? Honestly, you'll find really quickly a powder board is nothing more than a whiteboard. So I have one of those I carry with me in home health. It's just a whiteboard that I can sprinkle some baby powder down on it. It does the same thing. Cornstarch, there we were. Paper plate, sure, you could absolutely do paper plate, right? I can also use, if I'm having trouble, I can get my good old belt here. Right? So now I can do the same activity, right? I can keep my chair straight. Better to do a chair that doesn't move. What type of motion am I doing now?
Assisted.
Good, right? Active assist motion, because now my hands are helping, right? So there's multiple ways you can make this easier. What do you think? So now I've done it. I'm really good at doing it supine. I'm really good at doing it maybe even long sitting.
Sideline.
Sideline, good, right? Now I can progress that to where I'm down here. And I'm doing the same thing picking up and out to the side. I could also do it in what?
Standing.
Standing, right? Now I've made it more challenging though, because what have I added if I'm doing this in standing?
Balance.
Balance, good, right? So you see how that progression goes? We're going to talk about that this semester heavily, that we're going to look at progressing exercises. We're not going to actively work on that because your first clinical rotation, you're not so focused on progression of exercises. What you're going to be focused on is following that plan of care. If the PT says do supine hip slides, you do the hip slides, right? And then next semester when you have Dr. Reskin and I, again, we're going to working on progression of those exercises, right? The first clinical rotation is to get your feet wet and follow a plan of care. Does that make sense? All right, heel slides. I always thought heel slides was kind of a misnomer in the way it's worded, but really what you're talking about is knee flexion slides, right? So I'm gonna lay again on my back. We can do it seated, but I'll lay on my back to demonstrate. I'm gonna pick a leg to do. The other leg I'm just gonna bring up into hook line, because that way it's out of my way. I'm actually gonna do the other, that way the camera sees. And now what do I tell the patient to do?
Pull your feet back, kind of bend your knees.
Yep, bend my knee and slide your foot back to your bottom and out. Back to my bottom and out. Again, I'm working my hamstrings. If I've got a fresh knee replacement surgery, that's going to be rough because I've got a scar here, but that's helping to mobilize that scar. It's also helping to get that flexion back. And we're going to talk, ideally, by the time they leave the hospital, we kind of want about 90 degrees of knee flexion, right? So if I'm going to sit in a chair here, just to kind of think about it, if that is straight, 90 degrees is kind of where we normally sit. That's about what we ideally want when they leave the hospital. Well, why? What do I look like I'm doing here? I'm going home. I'm in a
Car.
Yeah. Right there. Think about it. If you've got like a Kia Rio or a Mazda 2, oftentimes you may not get enough space to put your legs straight out. Right? They're not exactly made for people that are over like 5'1". One of my friends has a Mazda Miata, and I always laugh when I get in that because I feel like I'm the great line from oh my God, the movie with Sylvester Stallone, The Expendables, where Arnold Schwarzenegger gets in that smart 4.2 car. He's like, I've got shoes bigger than this car, right? They're not made for that, but if they can get to 90 degrees, they can sit in a car pretty comfortably. If you get in a truck, this is almost required because you don't get a chance to get that truck seat doesn't really let you rest down like that. The other thing is going up and down stairs. So doing these slides is good. I can do it in seated here, right? I don't find this as effective because oftentimes I'm hitting a leg underneath. I don't have a ton of room to go back. If I have a standard chair, yeah, I could do that. Okay, what if pulling it like that, so pulling it back again, is too hard? How could I help them?
Hamstring strap.
Okay, good. Hamstring strap, or again, I'm just gonna use my good old black belt here.
Something to slide the foot to.
Yeah, I can start with, we'll see first of all if this is good enough. It's still too hard. Well, now I can take my towel or my pillowcase or whatever I want to do. I can put that under my heel. Put my strap over it. And now I made it easier. Oh, that's so much easier, Mr. McKeever. Thank you for making it easier for me. But remember, if we make it easier, we're reducing the overall muscle activity, right? So think about that as well. How could I eliminate gravity?
If we make it easier like that, would we just add more reps then?
Could, sure. Right? If you're looking at pure energy expenditure, right? You know, METs in, METs out. Sure, adding more reps would get a little bit more activity out of it, right? How could I eliminate gravity? What position could I put myself in to totally eliminate or minimize gravity's effect?
Sideline.
Sideline. Good, right? We're going to talk about this. Where's that stupid? Get off me, belt. Right? Now, this is a little silly doing it this way, but I've pretty much eliminated gravity at this point. There's nothing weighing down on my foot to hurt me from doing this. And I've done this in patients where, I'm trying to really get some flexion going. And I'm not necessarily working the muscles. I'm more worried about getting the range of motion. And we're going to find out when we do goniometry, sidelining is how we measure it if the patient can't do against gravity. If they had surgery on the knee and do these exercises, will they do both legs? Depends. I like to do both legs just because I think it's beneficial. I've gone in and done the wrong leg entirely for the whole session just because I didn't check the chart before I went in. Don't do that. And the patient's like, well, you know that my surgery is my right leg. I'm like, oh, I know. I just wanted to even you out today. Patient didn't know I screwed up. I went out going, I can't bill for any of that. Right? But if you do both legs, then it's positive. Then you can. Right? It's not a bad idea. How would I progress that? What do you think some progressions are that to add gravity? What would be a progression?
Resistance.
What's that?
Add resistance.
Good, I could add some resistance. I could put a weight on it, right?
What about
Prone, now it's changed the exercise a little, right? Now we're doing a leg curl. And we're gonna do that in a little bit. All right, we're getting through this, I promise. You guys enjoying this a little bit better than just listening to me lecture and ramble for hours? Good, Anthony can be honest, I promise. All right, short arc and long arc quads. Guess what the difference is?
The length.
Shut up, Siri. The length, the amount of distance I'm going, right? Short arc means a short arc. Long arc means a long arc. Typically, short arc quads are going to be done in supine with a bolster of some sort. This is all I have in my house. I don't have a big pillow. Oh, actually, I do have a big pillow. I'm just not going to go get it. I'm too lazy. So I'm going to use this, and we're going to pretend this is a big bolster. I'm going to take this, have the patient supine, hook lying, put a bolster under their knee. And now all they're going to do is a short arc from here to knee extension and back. Knee extension and back. Try to keep them from turning their feet out. That is not knee extension. I don't have a box. I'm going to grab a bigger pillow real quick. Hold on a second. I got a big fluffy pillow out of my guest room. Now I can use something a little better. Now I can put that under that leg. I almost hit my head. I'm not sure. Go away. And now I'm just doing up and back. A bolster works a lot better. Up and back. I can also be, if I'm the therapist, I can be that bolster by putting my hand under their leg and they're just doing about a 45-degree arc or a short arc. Does that make sense? Now, could I add an isometric at the end? Right? That would be a short arc with a quad set at the end. See how you're adding stuff? Because now I'm going to come up, arc, hold, 5, 4, 3, 2, 1, and down. So now I'm getting a concentric to isometric activity. The more common one is long arcs, because long arcs are ones you're going to do in seated. So now I've got about 90 degrees, so everyone's going to do these. Give yourself space to become a rocket, right? You're just going to take from here, You're not flexing the hip. That is not part of it. That's why I tell my patients, put their hands on their thighs. You're just going to kick up and down, up and down, up and down. Now I want you to try something for me. Turn your foot outwards and do that. Does that feel different? Right? What are you doing there? You're cheating. And patients are going to try to do that. What is it called when a patient cheats? Because we don't want to call it a cheat.
They're like being smart. Their body's like knows how to do it easier.
Body's trying to right. Good.
Shortcut?
Shortcut, good. Or the other term is a substitution. They're substituting for what they should be doing. That's a nice way of saying they're cheating. Does that make sense? Right? So if you see them going like that, how would you cue me to fix that? So I'm going like this.
Turn your toes inward.
Turn my toes in, good. Keep your toes pointed to the sky, right? Oh, that feels totally different. Good job, Anthony. Thanks for telling me that. Right? Now I'm doing a totally different exercise. And then I can come over and do the other leg. Same thing, right? Oh, that feels so good. Look at those quads firing. Oh yeah, look at those massive quads. I'm a monster. I don't ever skip leg day. Right? Now, some of your friends that you go to the gym with, they might do that, and that might be too much for them because they skip leg day every day. But we don't know one that skips leg day in this class. So does that make sense? The difference between a long arc quad and a short arc quad makes sense. Right? Short arc about 45 degrees with a bolster under it. Long arc is 90 all the way to extension. 90 all the way to extension. Thank you, Dr. Reskin. So we've done those quads. Now let's do the fun quad exercise, which is more, because it's more of a true hip flexion exercise than it is quad exercise, and that's a straight leg lift. What do you think a straight leg lift is going to indicate you're doing?
Lifting a straight leg.
Lifting a straight leg. Wow, you're like magical in thinking about this, right? So with a straight leg lift, I'm going to lay on my back. Oh God, this is getting my exercise here today. I typically will give a patient a goal of how high I want them to lift their leg. Usually what I tell them is lift up to the other leg that is flexed. So I can bring it up to that and down because I want control. What I don't want to see is this. And that's what you're going to get out of a kid the first time. You want nice and controlled leg lift. So they're going to bring the leg up, keep the toes pointed straight up into the air. Straight up and straight down. Straight up and straight down. Nice, slow, and controlled. So which part of that is the concentric part of that exercise?
When you lift up your legs.
Good, when I lift up. And then eccentric is when I do what?
Away from the body.
Yeah, when I lower it back down. That's why I want that control. You're getting a combo of a concentric, eccentric activity. So here's a trick question. What muscle is my main hip flexor?
Is it your rectus femoris?
Okay, that's an accessory hip flexor because that's a two-joiner.
Is it your iliac? Yeah, psoas. I was going to say.
Psoas, good, right? So as I was saying, that's your main one. I'm so funny. So this is funny. You'll have a patient's had a total knee replacement, and you'll have them doing a straight leg raise, and they can't lift the leg off the mat. They're trying, they can't get anywhere. What's happened at that point is they become so rectus dominant that because they had the surgery, the rectus is now all inflamed and they can't do that hip flexion. And I have one surgeon that I've worked with that used to come by and be like, you're doing those leg extensions. He'd come by and he'd lift their leg up. And he'd be like, keep that leg straight. Don't you dare drop it. And he'd let the leg down. And he'd be like, oh my God. Right? Okay, so good question. So Anthony asks, is an example of active insufficiency. At what point would I be actively insufficient? So are you talking about of the rectus femoris? Is that what you're talking about, Anthony? I can't see your camera right now, so.
I was talking about when the patient's lying down and he couldn't lift his leg up.
Yeah, so if I'm lying down, right, my rectus helps with straightening my knee. So it's already partially contracted, right? Does that make sense? So now I only have kind of that upper part of that rectus to help with straightening up. And it's really difficult for patients that have had it. So it is part of active insufficiency. It's more just when they do that knee surgery, they insult the tendon of the knee, and it just irritates the quads and that rectus femoris and just really kind of aggravates them all. And it makes it harder to do that. But they didn't do any surgery on the hip, so they should be able to lift it. And what you'll find is they'll start exercise and be like, man, it's getting easier, because they're starting to remember how to fire off that iliopsoas, because that's there. It's just kind of laying there like, hey, I'm taking a breather. Fun fact, does anyone know what cut of steak the iliopsoas is? I know that's for those of you that are vegans, but I'm sorry to break your bubble here. It's a fun fact. Does anyone know? Yeah, good. Who is that? It's Anthony. Filet mignon. The filet mignon. I'm sorry, Bianca. I don't mean to ruin this on you. I apologize. Yeah, Dr. Preston's like gross. So the filet mignon is one of the tenderest cuts of steak. Why do you think in a cow that would be a tender muscle? So gross. Because cows are on all fours. Think about it. If I'm on all fours, my iliopsoas is squished up. It's not being used a lot, right? So it becomes a really tender cut of, anyway, side note. I have all the rare facts. Okay, could I do a straight leg lift and seated?
It'll be called a march, right?
Well, I mean, that would be a bent leg lift, but I could, right? I could do it here. TMI. I could do it here, but I'm not getting a lot of motion. Why? What's kind of stopping me?
Your back against the chair.
Back against the chair. The other thing is I'm getting what's called soft tissue approximation. Right? I have right now what is called Dunlap's disease, where my belly Dunlaps over my belt. And my belly's getting in my way. Is there a way I could modify this and still do it seated though? What could I do in my chair?
Lean it back.
Yeah, good. I can lean it back, or I can just slide out a little bit. Now my belly's out of my way. I got some more range of motion, right? Again, what happens if I turn my foot out like this and lift up?
Pushing your adductors more.
Yeah, good thinking. I'm using my adductors more, right? And guess who's going to do that? Patients that have surgery. No, it's not on the NPT. No, it's not. Come on, I try to have a little bit of fun, Dr. A. I know she's going to throw stuff at me later. If I turn my leg out, now I'm using my, and you can almost see it, right? If you look here on the inside of my leg, see my adductor fire, right? Versus here, it's my iliopsoas. It's more up in here, right? So be aware of that. Don't let them cheat. All right, let's get a little more difficult. Straight leg lift with abduction. Ooh. Now what do you think you're having the patient do?
Swing the leg out.
Yeah, so I'm going to lift up, and there are a couple of different ways you can do this. And I've seen it a couple different ways. So I can sit here and lift out and go out to the side. I don't particularly like that one, but what I do like doing a little torture with my patients is bring the leg up, out, in, down. Am I doing a lot of eccentric control with that?
Yes.
Yeah.
Yeah.
Right? I have that iliopsoas has to hold that leg up the whole time I'm doing that abduction motion. So if I have a patient that might have trouble getting those straight leg lifts, that will help me because I'm getting a lot of eccentric control. And we know that we live in an eccentric world. Okay, something's going on outside. So I really like that when I have a patient that's having trouble with the straight leg lifts to work a little bit more of that eccentric control by holding that leg up there, kind of going out to the side. Now, if your PT does it where they lift out at a 45, that's what they choose to do. Just make sure you understand what they're putting down. I have names for all of these exercises. They may not be the same that you have in the clinic, right? That's why it's important to understand what your clinic does. Abnormal end deal. Love it. I missed that earlier. All right, four-way hip. This is a progression of a straight leg lift. The straight leg lift is only going to go up, right? And guess what? The four-way hip includes a straight leg lift. So my first one for my four-way hip is just doing hip flexion. So I'm going to do 20 of those. Okay, good. Now I'm going to add abduction. I'm going to switch legs just so I can demonstrate it. We already did that, right? Flip to the side, bring the leg up, abduction, right? Abduction out to the side. Now I've done abduction. Now I can do, what's the next step?
Extension.
Extension. So I'm going to lay on my belly. Get on my belly. And I'm going to lift the legs straight up. Now, what do you think are some, this is one that a lot of patients cheat on. Why do you think patients cheat on this one?
Lower back pain?
Yeah, lower back pain, right? You're like, I'm going to do this. Here's my leg, straight leg lift. Right? So they need to keep their ASISs on the mat and lift straight up. Even I cheat a little bit because I'm tight. So I've done flexion, I've done abduction. What's my last one for my four-way hip?
Adduction.
Adduction. This is the challenging one. And there are a couple different ways to do this one. So if I'm going to use this leg, so I'm coming up, right? I can either bring this leg in front and lift up and come into adduction, or I can keep that in the back and lift up. But I find that that causes me to flex a lot more than I should, whereas if I keep this here, it kind of gets my pelvis in a position I can't do that, and I can only lift up. Use a bolster, good, yep, I could. Right, I can lay a bolster here to protect myself, right? I can also lift both legs if I wanted to, but that's not a very comfortable exercise because that puts a lot of pressure on that greater trochanter, right? This way it takes a little bit of the weight off that greater troch. So that's a four-way in supine, but guess which way you normally see that four-way hip done?
Standing?
Standing, yeah, right? Because I can stand up here, right? I'm gonna slide back, and I can do my flexion straight up. I'm doing rocket kicks, right? Did my flexion. Oh, goodbye. Abduction. I can do my extension. I don't have a lot of room here, so I got to be careful. Step forward. Extension. Now, what do you think? How do you think a patient is going to cheat with that one?
Lean forward.
Yeah. Oops. I'm sorry, Sky. What links? Didn't mean to kick you. Right? They're lean, so you got to be careful. Nice straight back. Lift the leg up. And then adduction, right? Come across. So in and out.
Does it matter if you're doing the adduction like in front of the other leg or behind the other leg?
I don't know if there's any, I'm trying to think if there's any real, I find that behind is harder for balance for me. So I tend to do it in front. Because normally I'm standing behind them anyway, because what do I have my hand on? What are they wearing?
Gate belt.
Okay, belt.
Right? So if they come back here, they're kicking me. Right? But if they're here, they can actually still do it. I can make that really difficult because I can have them do now a four-way true hip. Up, out, back, in. Now what have I done? I've added what?
Balance.
Balance, right? And you guys saw left side not good for me on balance. Right side's a lot better, right? and I can change that up. I can make it so they have to do cognitive work with that too by saying, okay, you're going to do the direction I tell you. Flexion, out to the side, in across, back, now back, flexion, across the inside, back. Now I'm working a little cognitive work. So you can see how these progress and can get a lot more difficult if you work a little stuff. Now, if I'm just working straight exercises, so I'm just working TherEx, trying to get them stronger. When we're talking progression, so making it harder, and say we're doing that 4-way hip and standing, what is the first thing we should increase to make it harder?
Ankle weight or resistance bands.
Gravity.
Resistance.
Gravity. I mean,
we're already doing gravity. I'm saying we're standing up doing them.
Difficulty of the difficulty of balance.
Okay, so remember, I'm not talking about balance right now. Let's leave balance out of it for now. We're just increasing raw strength. If you want to get stronger, you do more of them.
Range of motion.
You can do range of motion too. Okay, good, right? What I'm getting at is usually when we're kind of working on TherEx, the first thing we do is say, let's do a couple more. So instead of doing 10, now we'll do 15. Instead of doing 15, now we'll do 20. Now they're getting 25 or 30 of them easy. Now we can start adding resistance bands. But the first thing I usually do before I add that is I add manual resistance. What is manual resistance?
Your hand.
Yeah, me. Why would I want to do maybe some manual resistance first?
You can control it.
I can control it. Good. And what else does that tell me?
well, it also like allows you to see how, like, where to start them on the weights.
Good. That's it, right? That's a great thought, right? It's manual muscle testing, right? Because let's say I go straight to blue. And so I'm going to stand up here. Let's see if I can hear you read this. No one got that joke, I hope. And I put, so it's, I was waiting for Dr. Reskin to yell at me about that. So now I go to blue and I first pick blue and I'm like, I can't do it. I can't do it. Well, that's because we didn't check how strong they were in the first place. Right? If I come in here and I get rid of my TheraBand, I put my hand on their hip and I'm like, okay, go out to the side. And they can only basically take a little bit of my hand. I probably only want to do yellow. It helps me gauge how much I'm going to make it harder.
So with that, then with progression, you're going to increase the reps, then do manual resistance, and then select the correct resistance.
Yeah, then choose a different resistance. I could do TheraBand. I could do ankle weights.
And then when you are choosing a resistance, are you going back to like the original reps? Like say we started at 5 reps.
It depends upon the clinicians or cables. Good, thank you, Dr. Reskin. I was like trying to think of what the word was. I appreciate it. You're reading my mind. Get out of my head. It's a scary place. Yeah, so usually in most clinics that I've seen, if I start adding resistance, they'll back down the reps. So say we're at 25 reps. Now we'll take it maybe back down to 15 because we added resistance and then start bringing the reps back up again. But it depends upon the theory that your PT is going on. If your PT just says, nope, we want to leave the reps the same and just add resistance, then you probably want to start a little bit lower in that resistance level to start with, right? So just remember, anytime that you add that resistance, though, it's making it harder on them and they're going to fatigue. If you've got an older person, what's going to happen to their balance as they fatigue?
Get worse.
It's going to get worse, right? This is why ABGB, always be gait belting, because as they get tired, they start getting sloppy. And how many of you guys will admit this? You know, when you're at the gym and you're really torquing it at the gym, you know, working really hard, not twerking, torquing it at the gym. You're really working hard. As you get later in your reps, you start getting a little sloppier. Anyone gonna willing to admit that? Yeah, okay, at least I got a few heads nodding, right? The more you kind of work, the tireder you kind of get a little bit sloppier with your form. You can see there are many ways to progress patient. It'll be confusing at first, but the practicums are there for you. Exactly. Thank you, Dr. A. And that is also why Dr. Reskin is such an excellent TherEx 2 instructor, because she's going to take what I'm going to talk about and we're going to add on it.
Sorry, I have another question also.
Awesome.
That's not like when we're increasing, you know, resistance, that's obviously not changing the plan of care. Like the plan of care will say progress. Like, my question is, I guess, is do we check with the PT before adding resistance?
That's a great question. As a new PTA, I highly recommend it, right? Until you've developed a rapport with your PT, I would recommend checking until they're comfortable with you and you're comfortable with them, and making sure you know what progression they want. Because maybe you do TheraBand, but they do a cuff weight, right? And you start progressing with TheraBand, and they're like, no, I want cuff weights because I want more force arm. Oh, okay, I'm sorry, I didn't realize that. Better to say, hey, you know, I've been working with Sydney for about 2 weeks now, and she's getting really good at those abduction motion. Can I add some weight or some TheraBand to them? Yeah, let's add some TheraBand. That sounds like a really good idea. That's still using your clinical reasoning, right? That is progressing the plan of care, not changing. Now, what would be, let's say a change would be.
That's progressing the treatment plan, not.
Thank you, there we go. That's why I have you here, because you're better than me.
And I rely on you to do the same thing for me next semester.
Yep.
Thanks.
So let's say I'm sitting here and the activity you have me doing is squat or sit to stance, right? First of all, open or closed chain activity.
Closed.
Closed chain, good. I just want to test you a little bit. And you're like, man, he's gotten really good at sit to stands. I want to have him do the leg sled, the leg press. Now that is structurally changing that activity. Depending upon the PT, they may want you to clear with them, right? Or maybe changing it from a closed chain to an open kinetic chain. The PT may want you to check with them because of protocols. This is where getting to know your PT is important. Getting to know you, no, just kidding. I'm not going to start singing, it's not happening. So you got to get to know your PT and understand it, and understand where their boundaries are with progression. And honestly, as a new grad PTA, this is where it gets hard, right? Dr. Ruskin said, you see how there's so many different ways to change this. It's good to get to know who your clinic is and what they do. And a lot of times that happens from working with different patients, right? This patient's doing no reps, this patient's doing with TheraBand. Oh, it looks like we do TheraBand for progression. So we're going to start doing that TheraBand for progression. Does that make sense? That answer your question there, Amanda? I know you look kind of, okay, good. All right, we'll do one, I got probably time for 2 more. All right, so I was really close to the mic there. I'm gonna blow your eardrums out. Prone hamstring curls. This is a progression of which exercise?
Slides.
Heel slides, good. Right. So I'm gonna lay down on my belly, get on my belly. And I'm going to bring the leg up, right? And I tell them, bend your knee as far as you can. Try to kick your bottom if you can. Boom. And then I can switch legs. Oh, no, I can't switch legs. There's a chair in my way. Switch legs. All right. Now, what if I can't do against gravity? How can I reduce or eliminate gravity?
Side lying.
Good. Yeah, see how this works? Ah, you seen some of this, right? So now I can come side lying again. And I can flex my knee. Now, if I'm in side lying, I do tend to grab a pillow or something to put between the patient's knees. We learned that in positioning and draping, right? So that we don't develop a what on those medial epicondyles.
Pressure
sore, right? Pressure injury. So now I can do this, and now I'm sliding on the pillow and not sliding on skin on skin. All right. Could I do it in sitting? Sure. Just a little more difficult, and I got to bring my chair up. And I don't remember which thing brings my chair up. That's the sad part. Yeah, I don't remember. Right? I can pull it back under. I don't like doing that one. Right? Remember when Dr. Johnson and I said we do that for a quick flexion muscle test? Remember we showed you that for that with the dermatomyosome, right? it's not really a good exercise here. It just doesn't go very well. But if I'm in prone and I've got that good, and maybe you've done some weight with me, I've done that good, how would you progress that one then from prone? Where would you move it? Standing, good, right? So now I can come, I have something to lean on. It's not a very stable, let me go to the outside here. And now I can do in standing. And then I can go back to adding progression as needed. But again, as soon as you get me up in standing, what should I have on? I'm gonna beat the belt, yeah. Honestly, even if I have them laying down, I tend to put a gait belt on them because it helps me be able to move them around in bed. But just anytime that patient is up, I don't care if it's, you know, you're working with Usain Bolt and he's really muscular, and obviously Usain Bolt's a pretty healthy person, right? I'm still putting a gait belt on Usain Bolt. Even if I'm working with Chuck Norris, and Chuck Norris would kick the gait belt off himself. Good, yep, you could think, yeah, absolutely. So Amanda asked, so would heel slides be a progression from hamstring sets? Sure, because we're going from an isometric activity to an isotonic activity, right? And then now you're at the gym. What kind of machines at the gym would you do for the hamstring curls? What's the
leg curl?
A leg curl machine, good, right? Or you could even get, you know, when you have those cables, you could take the cable, hook the cable around your ankle and do a cable pull with it, right? So there's all kinds of progression you can do here. So you guys are sitting here thinking, wow, these are really simple activities, but you can see how easily they become difficult, right? You make them pretty difficult pretty quick. All right, the last one we're gonna do, we'll finish the rest, we'll finish 19 on Thursday, but let's talk about supine fallouts and sideline clamshells, because they're kind of the opposite of each other. A supine fallout, I'm going to lay on my back again. I'm going to have my legs up in hook lying. And what do you think a fallout is going to look like? Has anyone seen these before?
Like kind of like butterflies?
Yeah, it's kind of like a butterfly. It's just kind of in reverse, because butterflies, we kind of go like this, right? A fallout is an eccentric activity. I'm going to let the leg fall out. I'm going to let it slow all the way down. And I'm going to bring it up. Slow all the way down. And I'm going to bring it up. Is that a lot of eccentric control to do that? Yeah, I see Truman nodding his head, right? You can't really do this one in supine because, or in seated, because there's no gravity there. This is one you really kind of have to do in supine. So then if that's a supine fallout, a clamshell you usually see in sideline. So a clamshell, I'm gonna lay on my side, and what am I gonna do? Knees bent like this.
Open up the top leg.
Yep. I'm gonna open up the top leg. So I'm like, okay, legs talk, legs closed, legs talk. Hey, it's Squidward. No. We're under the sea, right? Get it? No. SpongeBob, fine, whatever. I joke with my kids and they get it. You guys don't get it. I'm gonna bring it up. And again, the main thing to think about is eccentric control. So when they go up and out, that they bring it slowly back down. So you don't want to see this. They're lacking eccentric control. So another quiz here. And you can see I'm doing this the whole time. Butterflies is another term, yep. If I'm doing, hey, it brought me a picture of a butterfly up. If you're doing supine fallouts, what muscle is maintaining the eccentric, or what muscles are maintaining the eccentric control? So going from here, falling out to the side.
Would it be the adductors?
The adductors, good, right? So the whole group of the hip adductors, right? Versus sideline clamshells, now what is my eccentric control muscle?
Glute med.
Your abductors.
Glute med or my abductors, right? Good. Good. You see how that anatomy came back and is haunting you guys all over again? right? So quick, what is the origin and insertion of the glute? No, I'm just joking, not yet.
Not yet.
No, not yet. There might be some quiz questions coming up about that. So we have a couple more to go through, but I'm going to actually, we're at 5 o'clock here. So let me get back up to my camera. Whoa, that was almost not a good thing. Mr. Heaver almost needed the ER. All right. So are there any questions up to those sideline clamshells? Now you guys got a whole group of exercises you can practice with your significant others and your kids. So I am going to give you an assignment. There is going to be a forum post for you guys to respond to than this one. What I'm going to do is I want you to teach these exercises to somebody that either you live with or friends with or something like that. And I'm going to give you till next week. Right? So you have a full week to do this. What the forum post is going to be is I want you to teach this and tell me which one they had the most trouble with. I'll post it on the posting. I just have to make the posting live. So teach them down to sideline clamshells and come back and reply to that thread and tell me which one did they have the most trouble with and then why. Again, you're not diagnosing. You're not saying, you know, my significant other had trouble with prone hamstring curls because I think that they have muscular dystrophy. And the main reason I want you to think of why they had trouble is because that's starting to think back, is it a them problem or is it a what problem?
Teaching.
Yeah, teaching problem. Because sometimes that happens, right? I've had patients where I'll work with them for sessions and they can't understand a dang thing I'm saying because I got an East Coast accent or something, I don't know. And then I'm telling them about them being cattywampus in bed and roach up in the bed and they don't have understand. And then Truman's going to come in after me and I've tried for a week to get them to do pelvic tilts and all of a sudden Truman comes in and they're doing perfect pelvic tilts. It just may be that they understand him a little bit better than me. It happens, right? So we have about another, was it 18, 19? We have like another 12 or so to go on Thursday. Was this a little fun? At least a little different? You're starting to actually get some activity.
Yeah.
Dr. Vreskin, did you have anything to add that you can think of that you'd like to say?
No, I thought your demonstrations and your talking about all the ways to progress are just, they're spot on. It's exactly what you guys are going to be doing in clinic. So it's absolutely practical.
Yeah. Now, does this prepare you to do plyometrics? Sure, it actually does. It's not, I'm not teaching you plyometrics here, right? Plyometrics we'll talk about is when you're up in the air and you jump and you land and all that fun stuff, right? But in reality, plyometrics come off these basic exercises, right? If you do CrossFit, which thank God for CrossFit, it's job secure. I'm sorry, just joking. I'm joking. But all of this builds upon each other. If you don't have these basic fundamental exercises or foundational exercises, you're not going to get plyometrics as well. You're not going to get aquatic therapy as well. So you have to have some basic foundational activities to build on. So I know this seems really simple. You guys are like, man, I can do these. Like Jennifer's looking at me going, I can do these in my sleep. That's fine. Jennifer's healthy. Your patients aren't, right? And you're going to run into all kinds of problems when doing this patient. That's where we get back to that communications and troubleshooting. Are there any questions?
Yeah, you might have said this. How many do you want us to teach them?
Let's go with 5, because 5 is a good number for a home exercise program. How's that sound? I'll put that in the post as well. I didn't put a number. That's a great question. Let's go with 5 because 5 is a good home exercise program. So obviously pick the hardest ones you can think of because that way they sweat, right, Truman? Make them work a little bit. Your cat does not count. You cannot teach your cat these exercises. Jason. All right, guys. Thank you. I appreciate you guys were, at least I saw what I really liked. I'm going to say this up front. I really liked that I saw you guys writing down notes. I was so happy. I hope Dr. Vreskin was happy at that too. And I hope she noticed that.
I was happy. I didn't say anything, but I was really happy.
Yeah, like that's the main thing. Why do you think I kept asking you questions about the muscles? Because I want you guys to keep that in your head. You got to know them. It doesn't go away. Semester 1 and 2 is not gone yet. It will never go away. It'll be there forever. All right, guys, I'm going to stop recording.